Good morning to one and all present here. And after a very exciting and exhausting day one, we are heading to the academic session on the day two. So our first session will be on interventional pulmonology in lung cancer. And to moderate this session, I would kindly request Dr. Sudhir Prasad, Dr. Chaitanya Deepak, and Dr. Noorul Yakin to kindly come to the stage, please. So the first talk of the day will be by Dr. Gela Vishwanath on 8th TNM staging of lung cancer, what's new? Dr. Vishwanath Gela, kindly come on to the stage, please.
Very good morning, one and all. At the outset, I would like to thank the organizers for giving me this opportunity. In the next few minutes, I would be speaking upon the newer aspect which have come up in TNM8. Till January 1st, 2018, TNM7 has been in OG. From 2018, January 1st, TNM8 classification has been introduced after the new literature and new evidence has been available. So we'll see what are the new changes which have come up in this TNM8 classification. So why should we actually have a staging? So appropriate staging helps us in deciding the correct treatment plan, and it also tells about the prognosis and also tells us about the crude survival. And it's also important for healthcare providers to have one common system wherein the communication remains constant if we have a common TNM classification. And we can also, there's some disturbance. Can anyone help in the media? Yeah. So it also helps us in understanding the research including the clinical trials. So as of all of us know that we have T, N, and M descriptors which tell us about the extent of the local spread, N tells us about the lymph nodal spread, and M about the distant spread of the tumor. And all these T, N, and M descriptors have been combined into different stages, and the decision for treatment will be based upon the different stages. Now let us see what are the different types of staging which are in vogue. So C stands for clinical staging, which is any kind of staging which is done before initiation of any kind of treatment, which includes information from your clinical assessment, CT scans, and also from mediastinoscopy or EBUS. Whereas pathological staging is done after resection of a tumor, and it is done after the pathological assessment by the histopathologist. And Y stands for restaging of a tumor. Suppose if you have an aggressive tumor where you think that the surgery may not be possible, suppose if you give any treatment and downstage the treatment and reassess whether the tumor, whether patients can be taken up for any kind of surgery or not, that means you are reassessing the patient after a part of treatment has been given or all of the treatment has been given. So it's called as restaging. And if you have a recurrence, that it's called as a staging after recurrence R, and A for autopsy staging. So the data for TNM8 classification comes over a study of almost 90,000 patients over a period of 10 years in 10 different countries and 5 different continents actually. And let us see what are all the T descriptors in this TNM7 and TNM8. If you look at the classification on the left side, it is 8th TNM classification, and it's on the right, it's a 7th TNM classification. Up to 2 centimeters in the earlier classification has been labeled as T1A. However, as the evidence came, it has been understood that every centimeter increase in the tumor size leads to worsening of the prognosis and worsening of the survival. So that is the reason this up to 2 centimeters has been divided into T1A into 1 centimeter and T1B from 1 to 2 centimeters. Similarly, you can see the corresponding changes in both TNM7 and TNM8. And it has also been seen that the overall survival, if you look at this Kaplan-Meier curves, T1A 92%, 82%, 80, 83%, 76%. As the tumor size increases by each centimeter, the overall survival decreases. So the certain important factors which you should remember when you are classifying a patient based upon T extent is the size of the tumor, extent of the bronchial invasion, whether it is involving the main bronchus, and if it is involving the main bronchus, whether it is involving the carina or not, peripheral extent of the invasion of the tumor, and mediastinal invasion of the tumor, and presence of the satellite nodule. This is a very important slide. Look at all these descriptors, T1, T2, T3, T4, and on the vertical axis, you can see the size, bronchial invasion, peripheral invasion, mediastinal invasion, and satellite nodules. If you have a tumor which is less than 3 centimeters in size, without any visceral pleural involvement or without any bronchial invasion, it is T1 actually. And if you have a lesion which is 3 to 5 centimeters, it's coming into the main bronchus, however, but it's not involving the carina, and there is involvement of the visceral pleura as well actually. There is no mediastinal and mediastinal invasion actually, or any tumor nodules in the different lobe of it. It is T2. And T3 is 5 to 7 centimeters with invasion of the chest wall, invasion of the pericardium or the phrenic nerve. And if you have a nodule in the same lobe, it is considered as T3. And again, if you have a nodule in the different lobe, ipsilateral side, then it is considered as T4. So T4 is more than 7 centimeters with involvement of the carina, involvement of the diaphragm, involvement of the mediastinal structures, and a tumor nodule in the different lobe in the same side. And again, even if you look at the overall survival, after the pathological staging has been done from PT1 to PT4, it has been shown that from PT1 to PT4 actually, the survival actually decreases for each substaging of the classification. And this is the table which encompasses all the T classification. You can see that there are additional descriptors also. TX is basically if you have a tumor which is found in sputum or ball cytology, but the tumor cannot be assessed on bronchoscopy or CT scan, it can be considered as TX. And TIS is carcinoma in situ. And the other important things we should remember are if you have any atelectasis or obstructive pneumonia which is extending to the hilum, it is T2 actually. In the earlier classification, it has been considered under T3. So, and again, these are the T3 and the T4 descriptors which we have discussed. And this is the chart which importantly differentiates between TNM 7th classification and the TNM 8th classification. Certain important things are, one is the T1A and T1B. Earlier there were only T1A and T1B, but in the current classification there is T1A, T1B and T1C. And earlier T2A has been divided into T2 has been divided into T2A and T2B. Now the size cutoffs, as you can see, is different for T2 also. And I told you about the atelectasis T3, now it is T2. And if you can see that invasion of the diaphragm earlier was T3, now it is considered as T4. And there are no changes in the nodal description between both TNM 7 and TNM 8 classification. However, there is one important change in the metastasis. In earlier, there used to be only M1A and M1B. Now the metastasis has been divided into M1A, M1B and M1C. Let us discuss it later in the metastasis descriptors. So when you have multiple T descriptors which are applicable to your tumor, the highest T should be chosen. Suppose if you have a tumor which is 2 centimeters in size, however, it is invading the chest wall. So it should be given T3. Though the size is 2 centimeters, it comes under T1 classification. Since it is invading the chest wall, it has to be given a label of T3. So when measuring the size of the tumor, measure only the solid component. Sometimes there may be surrounding atelectasis, there may be a cystic component. So just measure only the solid component. And now let us see the nodal descriptors. So, and we have stations of lymph nodes starting from 1 to 14, ipsilateral and contralateral. If, station 10 to station 14, ipsilateral lymph nodes, which are called as hills actually. The mnemonic for this is hills, hilar, interlobar, lobar, segmental and subsegmental. If you have any ipsilateral 10 to 14 lymph nodes, it is called as N1 station. And if you have ipsilateral 1 to 9, which contains all the highest mediastinal, upper paratracheal, all these lymph nodes actually. If you have any ipsilateral 1 to 9 stations, it is N2 station. And N3 is any contralateral lymph node is an N3 station. If you have any supraclavicular and any scaly lymph node, be it ipsilateral or be it contralateral, it is considered as N3. So ipsilateral peribronchial, hilar and intrapulmonary nodes N1, ipsilateral mediastinal and subcarinal lymph nodes are N2. So this is important to understand. The subcarinal lymph nodes, though it's in the center, suppose if you have a tumor on the right side, if there is a subcarinal lymph node involvement, it becomes N2. Similarly, if you have a tumor on the left side, if you have a subcarinal lymph node, it becomes N2. So this is an example of a patient having right lower lobe mass lesion. You can see that the lymph nodes which are denoted in the green are the N1 stations. They are basically the ipsilateral, peribronchial and the hilar lymph nodes. And the ones denoted in the orange are the N2 station, where you can see that there are ipsilateral right paratracheal lymph node and the 2R lymph nodes, that is the upper paratracheal lymph nodes. And the ones in the yellow are the contralateral lymph nodes, N3 stations. So coming to the metastasis descriptors, as I've told you, it has been divided into M1A and M1B actually. So if you have an metastasis which is confined to the thorax, it is M1A. So it can be anything like a pleural nodule or a pericardial nodule, pleural effusion or an pericardial effusion. So if you have metastasis spreading outside the thorax, then it becomes M1B and M1C actually. So if you have a single site of metastasis, that is called as oligometastatic disease, it's called as M1B, and if you have multiple sites of extrathoracic metastasis, it comes under M1C. And similarly here we can see that in the TNM8 classification, the prognosis is different for M1A, M1B and M1C. So these are the descriptors for the M1. One more important thing to remember is if there is an involvement of the single non-regional lymph node, that also comes under M1B actually. Sometimes there might be a lymph nodes which is outside there might be an abdominal lymph node or inguinal lymph node which is involved with metastasis. That becomes an M1B in this scenario. And other thing is when you have pleural effusions in a patient, if your cytology is negative and if you do a thoracoscopy and pleural biopsy is negative, then you can label these patients as having paramalignant effusions. So the pleuropericardial effusions which are paramalignant should not be considered as metastatic actually. We know that there are different mechanisms for effusion formation like pericardial and pleural effusion in malignancies. Sometimes it can be non-metastatic as well. So for future survival analysis, always document the site of metastasis, the number of metastasis and the size of metastasis, whether it's a clinical diagnosis versus pathological diagnosis. Certain optional descriptors are also given in the new classification, which is nothing but the LX is the lymphatic invasion and V is the venous classification. So after the dissection of the specimen, the pathologist tells us whether the lymphatics are involved, whether the venous invasion is present or not. So after clubbing all these T, N and M descriptors, we get this TNM classification. Okay. So this is a very busy slide. However, you should remember that if you have any N2 lymph nodes involvement, so it is either 3A or beyond 3A. And if you have any N3 involvement, it is either 3B or more than 3B actually. And any metastasis, as I told you, becomes stage 4 disease. And all the T1 to T4, N0 to N1, M0 becomes from, is classified under stage 1A to 3A. So coming to conclusions of my slide actually, my presentation, every increase in centimeter of the primary tumor is significant and new subgroups have been created to accommodate these changes, and it is important to know that the survival changes for each centimeter increase in size of the tumor size, and descriptors not only the nodal station which is involved, but also the number of nodes which have been involved also have been given different notation actually. You have N1A, N1B, and if you have again N2, that is again, if you have a single lymph node involvement, it is classified under N2A, and if you have multiple lymph nodes, N2B, and it also they have also seen whether there is a microscopic involvement of the lymph node or whether it is a gross involvement of the lymph node. That also has been subclassified. And as I told you, that there is no change in the N descriptors. The N descriptors remain same between both TNM7 and TNM8 classification. And coming to the M descriptors, the number of extrathoracic metastasis is also significant. Earlier it was divided only into intrathoracic and extrathoracic, but here in the extrathoracic metastasis, extrathoracic single metastasis versus extrathoracic multiple metastasis have been importance, and different subgroup has been created. Thank you all for patient listening. If there are any questions, we can take up any questions.
I think with the latest classification, I think the size matters, and then with the interventions, more early diagnosis and the staging, treatment can be given for better survival for patients. I think if no questions are there, we'll call the next speaker. Thank you, Dr. Vishwanath.
Yeah, thank you.
Thank you, Dr. Gela, for an elaborative discussion on the 8TNM staging of lung cancer. To move on to the next talk, we have our speaker from Singapore, Dr. Devanand Anantham, for a talk on the current role of the EBUS and the USB in lung cancer. So please.
Good morning. Thank you for joining us on this Sunday morning. I guess my role is going to be to set the stage for the following speakers. As always, my slides have already been uploaded on Facebook, and I'll make a quick plug for the coming conference in Singapore, which is the World Conference of Lung Cancer, which will be in August. So please come and join us if you can. So for those of you who were at the Convex EBUS focus class yesterday, this will be a little bit of a revision. Again, I'll show you a patient of mine who is a smoker presented with hemoptysis. And for the astute clinicians here, you know that when the chest X-ray looks normal, look behind the heart, and you can see that there is a retrocardiac mass. And my first question to all of you is, what is the stage of the disease? So I know that India now has over 150 EBUS facilities already, and a lot of you are doing EBUS. So I'm not going to talk so much about EBUS for diagnosis of lung cancer. I'm going to focus on EBUS for staging. So if someone asked you the stage and you just heard a fantastic lecture on the new classification and staging of lung cancer, the first question you should ask your radiologist is how big the lesions are, right? Because depending on the size of those lymph nodes, you will get a different stage for this, a different radiological stage, and that will translate to a different prognosis, right? And the treatment paradigm is completely different. So given that this patient has got a left lower lobe mass and an enlarged subcarinal lymph node, what would be the approach? Would it be to do a PET scan? Would it be to do a bronchoscopic biopsy of the primary lung lesion, to do EBUS, or send this patient for surgery, do a mediastinoscopy, and do a frozen section? If the frozen section is negative, to go and do a completion lobectomy. Well, as we think through that, I wanted to put up this paper, I think that was shared again in our talks yesterday. Dr. Yasufuku's paper shows that pathological staging trumps radiological staging, right? But what's special about his paper was that it was not pathological staging by surgery, but pathological staging via a needle biopsy. So even pathological staging via a needle biopsy is far more accurate than either a CT or a PET CT. Now, the options for pathological staging can obviously be divided into the surgical options and the needle biopsies, and I'm not going to go and talk about the potential complications and risk of the surgical options. And we're here to talk largely about the endosonographic options. And EBUS, as you may well know, gives you access to the paratracheal, subcarinal, hilar, interlobar, and lobar stations in most patients. And when in our hurry to do EBUS, I've always made a plug. Please, please, please study the CT scan carefully. If you look at all these CT scans, they all look like lesions which you could put a needle into via the EBUS scope, but I would encourage you not to, because you do not want to be putting needles into the zygous vein, the esophageal varices, bronchogenic cysts, or hiatus hernias. So study the CT scans carefully. Unfortunately, I've actually seen all these lesions biopsied. There are stations which we cannot reach by EBUS, the prevascular and prevertebral stations. And then there's station 5, which is not accessible by EBUS, which is accessible by EUS, station 6. And then the lower mediastinal stations, the paraesophageal and pulmonary ligament stations. And these are accessible through EUS. Of course, pulmonologists have felt frustrated that they have had to refer these patients out, and some pulmonologists have put the EBUS scope into the esophagus and doing EUSB or EUS via a bronchoscope. My own feeling on this is that it's going to be largely determined by the credentialing requirements in where you work, right? So in places where the gastroenterologists are very tight with their credentialing, it is very unlikely that pulmonologists will be doing this. In places where there is collaborative work between the pulmonologists and the gastroenterologists, you will see a lot of this. So, for example, in Europe and in East Asia, this is not uncommon. And the diagnostic yield of this has also been equivalent to that of EUS. A quick word on EBUS and comparing it to surgery. I know this is a little bit old, this paper, but it's a good paper by Professor Yasafuku, comparing lymph nodes biopsied by sampled both by endosonography and by surgery. And these, as you can see, are small lymph nodes. And you can see the diagnostic accuracy is equivalent. And even in expert surgeons' hands, the surgical procedures have got some complications, typically hematoma and injury to the recurrent laryngeal nerve. But I think this paper tells us something more than the fact that these two procedures have equivalent diagnostic yield. When people say that they are equivalent diagnostic yield, it doesn't mean they're equivalent procedures. So if you look at the small print on this, you'll see that the inadequate samples by a needle biopsy is 10 times greater than the needle biopsies via the surgical biopsies. And this is not unsurprising. Poking a lesion is not the same as taking the whole lymph node out, right? So it just happens that when you're diagnosing and staging non-small cell lung cancer, the number of passes we do and the number of jabs we do per pass mean that this difference is not important. But in other diagnoses, this could be important, right? And which is why the diagnostic yield of EBUS in things like lymphoma and so on, where histology is required, is not as encouraging. So if you put everything in perspective, you can see that the diagnostic sensitivity of mediastinoscopy, EBUS, EUS are fairly similar. What is different is the false negative rate, right? So that's what I was talking about in the previous study. So if your EBUS diagnosis is not consistent with your clinical pre-test diagnosis, don't necessarily believe the EBUS biopsy, right? The patient may need a rebiopsy or may need a surgical biopsy. So coming back to our patient, with a tumor and a discrete lymph node, the guidelines suggest that these patients do need to be staged. And ideally, we should try and do the staging and the diagnosis at the same time. So an EBUS, in my mind, would have been the best option. And there's data to show that this is a cost-effective strategy. This is from Australia. This is from our institution in Singapore. That this approach is not only gives you a quick diagnosis and staging, but also is cost-effective. So coming back to the patient, let's assume now that instead of having that subcarinal lymph node, the patient has got a normal mediastinum. So lower lobe mass, normal mediastinum. So what should we do now? Would we do a PET-CT? Do a bronchoscopic guided biopsy of the lower lobe lesion? EBUS, the normal mediastinum? Or send the patient for surgery. Again, do a MED. If it's all negative, frozen section, then go and do a completion lobectomy. Well, we've known for some time now already that even PET normal PET normal mediastinums, when you do EBUS, you can pick up malignant lymph nodes. And it is for this reason that the guidelines tell us that in high-risk patients, patients who've got central tumors, patients who've got N1 disease, you should go and stage the mediastinum even if it looks normal on PET or CT, right? So you should go and stage these patients. There's also emerging evidence that if the SUV is high, or that if it's adenocarcinoma, or it's a very large lesion, you should also do this. But in the guidelines, it's central lesions and N1 disease. Of course, the other question is, can we combine modalities? EBUS and EUS, right? And probably the best evidence for this comes from the ASTER trial, which showed that EBUS and EUS together approach the diagnostic yield of a mediastinoscopy. And they suggested that 11 patients who had a negative EUS EBUS would be needed to detect one patient. And if you did mediastinoscopy on all these patients, you need to do 11 of these negative studies to detect one occult N2 disease. The obvious advantage of doing EBUS and EUS together is that both the procedures can be complementary. They can reach stations that the other can't reach, and you can double sample the stations that they both can reach. And of course, this led to a lot of people trying to figure out, should we do EBUS first? Should we do US first? And so on. And those who like to do EBUS will point out that, the EBUS group in this study, as the accuracy of the first procedure, the EBUS group was slightly higher than that of the EUS, although not significant. And of course, those who are believers in EUS will tell you the EUS doesn't require as much sedation, and if you've got the diagnosis on the rows, you no need to proceed on to the EBUS. And also, EUS will allow you to sample the adrenals, which is an M1 station, which gives you a high station. Either way, the survival data shows, 5 years down the road after ESTA, shows there's no difference between surgical staging and endosonographic staging. So the next question I'm asking is, let's say we had that first patient, left lower lobe mass, subcarinal lymph node. That's the EBUS image of that patient. We sample it. It comes back as non-small cell lung cancer. What should we do? Should we start chemotherapy? Should we discuss with the pathologist? Should we send the patient for a surgical resection because it's only a single station, stage 3 disease? Or should we complete the staging with an MRI brain? And I'm sure all of you know that in 2020, a diagnosis of non-small cell lung cancer is no diagnosis at all, right? You need to subclassify it. So our pathologists are being asked to do more and more things with less. They absolutely have to classify the lung cancer, and they've got to send the tissue for molecular studies, and of course, there could be benign pathology as well, right? So this is about how, if you're going to do EBUS, it is a team effort. I already talked about the working with a radiologist. You also need to work with your pathologist. And from this sample that I send my pathologist, right, my pathologist has to organize how they're going to manage that sample. And this is the routine molecular profile that is done for all our patients in our lung center. And this is done reflex. We don't order this, it just comes out, right? And I'm sure that, with next generation sequencing and with, the reduction in cost, this will be coming to you all as well soon, right? So you need to communicate with your radiologist. Next patient, this patient has got a small right upper lobe solitary pulmonary nodule, looks like cancer, smoker. What should be the next step? Should we do a PET? Should we do a bronchoscopic, maybe a guided biopsy, one of the new navigational techniques? Should we EBUS the normal mediastinum? Or should we do a CT guided biopsy, right? And the reason I put this up is that I don't want you to feel that I'm here to sell EBUS and we should EBUS everything. The guidelines tell you that for very small lesions in the periphery of the lung, you don't need to go and you don't need to do pathological staging of the mediastinum. Okay? You don't have to EBUS everyone. I'm almost done. This patient has got lots of lymph nodes, right? Subcarinal, paratracheal, and so on. The history is suggestive of cancer. What should we do? PET? Needle a palpable supraclavicular lymph node. EBUS the mediastinum. This will be a great case for a beginner to do. Okay? Or even can do conventional TBNA, right? Or thoracentesis. And I'm sure all of you chose thoracentesis because that will stage the disease as well as diagnosis. So that's what we want. That's what I'm trying to build on the previous lecture on staging. So where possible, we want to do the staging and the diagnosis at the same time. Just because we can do EBUS, we don't have to do EBUS. When you've got such extensive lymph nodes, you can assume that they're all going to be malignant, right? So this is the summary slide. For extensive disease like this, you don't have to prove it. Obviously, if that's the only site of biopsy, then it's a very easy EBUS to do. If you've got a central lesion or an N1 disease, even if the CT or PET scan is normal, you should go and do staging of the mediastinum. If you've got a discrete lymph node, don't assume it is malignant, even if radiologically, the radiologist quite justifiably tells you it is suggestive of malignancy. Don't assume it. The rate of false positives is relatively high. You should go and prove them. And then if you've got a very peripheral lesion, With a normal mediastinum, you don't have to go and stage the mediastinum in those cases. As more and more of us are moving from diagnosis to staging in EBUS, I just want to remind us that we must compare like for like. And just doing 1 or 2 stations in the mediastinum is not called staging of the mediastinum. It needs to be done in a systematic and thorough way. So there are actual definitions for what complete staging is. I'm finishing. Systematic staging, selective staging, and poor staging, which is basically just looking at the lymph nodes or using your elastography and saying malignant, non-malignant, right? And as a community, if we want to be taken seriously in the business of staging, we should be aiming for at least systematic staging for all patients who are referred to us for lung cancer staging. You've heard about that 8th classification or 8th edition of the tumor staging. Probably in the 9th edition, you're going to subclassify the lymph nodes, right? Which will mean there'll probably be more EBUS work for us if each of these subclassified lymph node stations are going to mean a different prognosis. I'm going to end by saying that I'm not here to advocate for EBUS or EUS or mediastinoscopy or any procedure. What procedure you use depends on the availability of the procedure, the expertise, the location of the lymph nodes, the physiology of the patient, the cost, and how complete you want the evaluation to be. But what is really important is that you do tissue sampling. That is the take-home message, right? Tissue sampling trumps radiological staging. And I'll put up this slide to show you that there is data to show that if you follow guidelines, and I've shown you a number of guidelines, if you follow guidelines, you will do less procedures on your patient, it will be cheaper, and it will cause less complications. So please follow guidelines. My take-home messages for you are, do not use radiographic scans as proof of metastasis. Plan ahead and order tests simultaneously, right? Where you can, try and diagnose and stage at the same time. Follow guidelines. Obviously, you can use clinical intuition, but you cannot be using clinical intuition such that you're not following guidelines at all. Use a multidisciplinary model. Thank you very much.
Thank you, Dr. Dave, for a very enlightening talk. I always like to listen to Dr. Dave because his talk is always inspiring, enlightening, and very easy to understand. So since we are entering 2020, just want to ask, how do you foresee the future of EBUS? Any possible innovation that you foresee for EBUS since we are entering new decade of 2020? Thank you.
I think the innovation you're going to hear in the lectures to come, all right? I think this is, what's going to happen is that more and more people are going to use EBUS, and soon EBUS is going to become part of standard bronchoscopic procedures. EBUS is going to move from the advanced bronchoscopy to the standard. It's going to be part of standard training programs, which is a good thing. I think that the next big step for us is from moving from those large lymph nodes to doing systematic staging, which requires more skill, and that will require us to be more rigorous in how we train. I think that we'll be challenged by circulating tumor DNA, right? I don't know how that will pan out. Maybe it's a reason to come for the World Conference of Lung Cancer. I hope that managed to evade your question as much as possible.
Any further question from? Maybe you can come to the microphone at the center there.
Sir, reasons for discrepancy between the PET positive or the pathological positive nodes that you are saying, even if there are negative on the PET, we should go for mediastinal staging with EBUS. Like, what could be the reasons for discrepancy when it is not PET positive?
There are several reasons. One is that if your tumor burden in your lymph nodes are low, they're not going to light up. And similarly, you can clearly get reactive lymph nodes from a tumor. So those lymph nodes are going to light up. And as we talked about yesterday, even treated lung cancer can get non-TB related granulomas and so on, like a sarcoid-like reaction, and those can also light up. So there are quite a few common reasons why there's a discrepancy between what we see on PET-CT, even very well done PET-CTs, and when you actually sample the lymph nodes.
Okay, thank you. Okay, I think we can move to the next speaker. Thank you, Dr. Dave.
Thank you, Dr. Devanand, for an excellent talk. So to add more spice to the EBUS, we have a talk on the EBUS in 2020, Thin Scopes and Thick Needles by Dr. Kylie Hogarth from USA.
So I decided, okay, great. I modified the talk a little bit because with the limited amount of time, I thought, and the large and huge role with the need to stage the mediastinum, I thought we would focus a little bit more on the tools we have. Because when it comes to peripheral bronchoscopy, there's a whole bunch of different technologies, but the literature on which sampling technique to use in the periphery, I think, is still up for grabs. Later this afternoon, I'll be putting a plug-in for robotic endoscopy in the periphery as opposed to doing linear EBUS. Because, as stated earlier, so the first two talks were fantastic because in the years that I think all of us have been doing bronchoscopy around the world, I've never seen something explode the way that linear convex EBUS probe has taken off. And the reason, of course, that it has taken off is it's less invasive and allows us to acquire a good amount of tissue if we use proper technique and follow our guidelines for appropriate staging. I'm a big fan of doing, I'm not sure why this is jumping through all my slides. Give me 1 second. All right. We are giving our pathologists less and less material and doing more and more with that less material. But you can actually get very good samples using endobronchial ultrasound. This was a nice recent meta-analysis of 28 studies using EBUS TBNA for the identification of molecular markers, which is now probably one of the most important components of lung cancer management. And the pooled probability of obtaining a sufficient sample for both EGFR and ALK mutations at roughly about 95% is pretty incredible, and this is across multiple studies, across multiple skilled centers. But right up front, when we're doing EBUS TBNA, one of the first things you have to do is have a clear discussion with your pathologist. Because no debate, not all pathologists are the same. It was why last night during the case competition, one of the questions asked was, were the slides re-reviewed on the so-called non-diagnostic cases? Because, for example, when a lymph node is sampled, epithelial cells is definitely not adequate. But finding either granulomas, inflammation that's granulomatoid, anthracotic histiocytes, or normal lymph tissue is a diagnostic EBUS. And then obviously cancer as well. And so the ability to see that, I will up front suggest that the next thing you should invest in within your bronchoscopy suite is your own microscope so that you can look at the slides yourself. Because it's as we'll talk, there's an active discussion with pathology at all times as to whether something is an adequate sample or not. So, is more better? Should we go in there and sample the node and just stab and stab and stab? What if you don't have rows? If you take a pass and you agitate several times across the node, the diagnostic yield has shown in this great study by Hans Lee that by about the third pass, you've plateaued, assuming proper technique. So rows is useful, but not necessarily required to achieve adequate tissue. That you can get terrific quantity of tissue, but that plateaus by about that third pass. So then it always comes up is what size needle? There's a lot out there, a lot of different companies, a lot of different sizes, a lot of different needle tips. There's been some gathering data that maybe help guide us as to what may be preferred. Of course, there's many factors involved. Some of it, of course, is what may be available to you and your region. Some of it is, of course, always driven by cost. Some of these can be relatively inexpensive disposables, but the amount of people that we are using them on, even a low-cost item becomes very expensive by the quantity. When you look at the classification of a histologic specimens obtained using EBUS TMBNA, 21 gauge versus 22 gauge, a couple of key things to point out. Size-wise or quality-wise seems to be about the same, but you definitely get more blood on the larger needles. We are a little behind in the pulmonary world. We need to follow some more from our brethren in the GI world who have been moving towards smaller and smaller needles due to less and less blood contaminant. There's now 25 gauges available within the US and around the world that are giving equivalent yields but with less blood contaminant. Now, when you also look, the histology across both are quite excellent. There's probably one of the little known secrets in pathology when it comes to TBNA sampling. What's a core? Everyone says we need cores. What is a core? Has anyone ever looked up the definition of a core? It's not in a single pathology textbook. A core, as defined by all the cytopathologists that I've worked with, is anything visible that they can actually see and could pick up with tweezers. So the tiniest little piece of tissue floating in some cytolite, that's a core. Big chunk that everyone can see from across the room, that's also a core. So there's a key here. It's all core implied that you must be hitting the lymph node with the world's largest needle and practically resecting the entire lymph node during the EBUS, and that's just not true. When we also take a look on the 21 versus the 22, the ability to pick up benign lesions, it's equivalent there as well, and then same with non-small cell. So 21 versus 22, plenty of evidence of no real difference in yield. There's growing evidence for really technically no difference, though maybe less blood. And you'd say, well, in the 22 versus 25. Now you may ask, why does that matter, the blood? Again, this comes back to the threshold of comfort for your pathologist. If there are lymphocytes on the slide, that implies lymph node. But if there's a lot of blood on the slide, there will be lymphocytes on the slide from the blood. And so it's being able to give your pathologist the higher comfort level of calling normal when they see less blood on that side. The 19 gauge definitely has the ability to get a larger quantity of tissue per pass. There's still pending literature on whether there's higher complication rates due to the size of the hole that's being passed. So there are several needles out here. I'm going to talk about one in particular because it's relatively new. But we've got ones from, at least in the US and some around the world, between Cook, Metaglobe, and the Olympus needles, and then the Boston Scientific needles, all coming in various sizes and each having their own pro and con. One I do want to talk a little bit more about, and it's only because of some of the data that's come out for tissue acquisition, has been a new needle that I know will be coming out in India in about 9 months. The acquired needle, as you can see as I zoom in on the picture, it won't, but okay, it's a very different tip and actually does gather very large cores of tissue. Again, any core is any size, but in the world of needing more and more markers and the ability to do stains, getting tissue of this quantity with a couple of passes of an EBUS needle is pretty nice. This is all built off of the EUS experience. The biggest problem I think we have in pulmonary is we're just 10 years late to the game and we're just following our friends in GI. There's terrific data from the EUS world that this type of a needle that has this tip that penetrates and acquires more tissue in bigger, larger cores just simply has been miniaturized for the lung. So there's been a clinical evaluation of looking across needles, and this was the idea of the 19 or 22 in a swine model. You definitely got larger sampling from a 19 gauge, but then when we look at the acquired needle, there's the question of whether this is any good or not. This is first 107 patients, and we'll go through this real quick because I don't want to run out of time. And wow, that really doesn't broadcast very well. So let me just summarize it. The overall yield with this newer needle was 97% on the first attempt, 99% on the second attempt. Malignancy, 96% on first, by the 100 by the second. Sarcoidosis found in 96%. Core sample being present, physical pieces floating, 87%, which definitely surpasses what we see with other types of needle. and then patient-related complications, none. And this is still relatively new. I think in the end, in my own personal suite, we keep several different needles on the shelf. We can talk offline, but there are several different clinical scenarios where we may choose to switch from one to the other. Now, do you need suction? Because in the end, this is all about technique. You can use whatever needle you want. Does suction make a difference? Suction is not associated with a higher diagnostic yield when compared with the no suction or the non-so-called capillary technique. This was the nice paper put out by Roberto Casal. You definitely get slightly less blood, but in certain fibrotic nodes, you typically need to add suction as well. So do not necessarily make suction one of your requirements for sampling lymph nodes. Technique-wise, we think of that ball. The biggest mistake I watch my trainees make is pass the needle down the same pathway over and over and over and expecting a different outcome. If you sampled it the first time and it was either not cancerous or non-diagnostic, sampling the same exact place the second time, what do you think the diagnosis will be? Alter it. You got to go from capsule to capsule because adenocarcinomas, 20% of people will only have subcapsular involvement. So I watch plenty of people shove that needle right to the middle and just sample right across here, forgetting the fact that under the capsule is where a lot of adenocarcinoma hides. So the so-called benign nodule or node isn't necessarily benign until you've sampled all of it. And then your next pass should be over on this side of the node and then down over here as well. If we don't follow those techniques, this is one of the ways that we have, of course, sampling errors. Another thing my partner, Dr. Murgu, utilizes is how to sample. What is your actual technique once there? You've picked the node, you're going to sample across the node, capsule to capsule. You're also, of course, have chosen whatever needle. But the frequency, so fast 1 to 2 downstrokes with quick jab in to cut the nodal tissue. Because they're ultimately conducted in via capillary force. Amplitude, you want to move the needle capsule to capsule like we talked about. Then suction, no suction needed. Though you can add a little bit of air if you find your yield is being very low because it's a fibrotic node. Time, spend very little time inside the node. You want to minimize that trauma. Edge, keep the needle inside the node at all times during the aspiration to avoid, obviously, contaminants from epithelials. And then the route. We used to think you had to stick to the same route once you were in the node, but again, our cytopathologists taught us this from when they sampled thyroids and subcutaneous nodules. Come at it at multiple angles, so we fan the route, we fan up and down through the node, changing the flexion, changing the rotation. It's a 3-dimensional structure that you're visualizing on a 2-dimensional screen. Sample the 3D component of it with each pass. Once you take it out, of course, we can throw it into various preservatives. One of the best things you can, of course, do is right up front have a discussion with your pathologist and what they like and what they don't like, what they want to use. The single best discussion I ever had with my pathologist and why 6 years ago we stopped using any brushes in the periphery, my chief of cytopathology just looked at me and said, I will never call cancer off of a brushing sample ever. I said, ever? He's like, ever. So we stopped stocking brushes. I recognize plenty of people like brushes, but I got a guy who says he'll never, ever make the call off of a brush, ever. Why would I bother to use a brush, right? Our folks love using Cytolite. We've got a new guy who loves using RPMI, not just for flow cytometry, but actually because it then forms better clots and he gets better cell blocks. Again, what do I care? I've acquired the tissue. I need someone to do something appropriate with it. EVIS, of course, is great for many things. Sarcoid, quite useful. Lymphoma, broad range, typically where larger needles may come into play and a need for flow cytometry. The ROSE workflow, we call our cyto team if you have ROSE, and I strongly advise if you can get it, it is a helpful thing, if nothing else, just from a tissue adequacy. They make a smear, they stain it with DiffQuick, they check the slides under the scope, and they provide adequacy to the bronchoscopist. So here's me taking a sample with our technician, walking over to the microscope. You can see in the background, we're lucky enough to have a digital scope so we can look at it, and so then I can argue with my pathologist as to whether or not things are adequate or not. But right then and there, we can argue for adequacy that we have enough tissue to do next-gen sequencing across, obviously, the entire mediastinum. So there's also one other new tool that we've started to utilize after you've made a puncture hole. So we keep talking about needles, but it was stated earlier, one of the theoretical advantages still to mediastinoscopy if you can find someone, at least in my country, who still knows how to do one, because mediastinoscopy rates have plummeted by 90%. One of the theoretical advantages is you get bigger, true pieces, right? Almost a resection of the node. Though if you look closely at the mediastinal literature, the amount of non-diagnostic mediastinal resections, it turns out the mediastinum does not look like a Netter diagram. They don't just sample the green things. There's a lot of missed nodes. But now we have the ability, after we've made a hole with our needle, to then pass it in a microforceps that are specifically designed for this purpose. You get a true histology sample. This has been very useful in our lymphoma cases. Now, with my remaining 28 seconds, I thought what you'd do is teach all of us the quick ability to do rows. So what do you have here? From the screen, there's a lot of blue. You'd say, we must have done a really good job. You did. You got benign lymphoid cells. It's definitively an adequate sample. You prove that this person does not have anything malignant in there. What about going on here? We've got a lot of anthracosis. Adequate. This was my smear, my call, then confirmed by the pathologist. There, this one the fellow did. That's why we got a lot of blood. And I'll end there, other than to say this is something that you and I can all do. Because on necrosis, you look closer, and then you can see the squamous cell. No, you can't make the official call, but you can bring rows to yourself automatically. And so with that, I'm going to shoot through these real quick, get to the last slide. Boop, 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 and whoop. There we are. And thank you very much.
Thank you, sir, for the
This is my institute
speech.
there, and then if you need to reach me, forgot the +1 there in the beginning, but you can call or email. Happy to, of course, share my slides with anybody as well. Questions at all? Terrific. Thank you, everybody. Oh, you have a question.
I am a medical oncologist. So as you said, we do have fear along with pathology when we are sending a patient for intervention. Like we do.
I'm going to come over. I can only hear an echo. Literally all I hear is this echo from the...
Yeah. We do have a fear of obtaining less tissue when we send a patient for intervention, this type of things. So we want more tissue for a better workup of the patient. So in your experience, like how many times you will go for a second procedure on the patient?
Great question. So how often is a second procedure needed, right? One of the reasons that we have rows is to make sure we never need to do that second procedure. As soon as my pathologist on the slide says that there's enough tissue, I take 2 more passes. Because once a pathologist says it's enough, it's still not enough, right? If nothing else, the oncologist will later decide they want something else done. The only reason now we're taking people for second bronchoscopy is for people that have had a needle biopsy of a lung mass with no staging. So then I guess it's a first bronchoscopy, but a second procedure. Because though there was adequate tissue, we don't know what stage. And so then we're forced to put them through yet another procedure to prove stage. But for me, the whole value of rows, it's not about being able to walk out that day and say to the patient, it's cancer, though that's nice. It's a nice bonus to be able to say that. It's to know that as you're done sampling, you have plenty of tissue in the jar and on the slide. Importantly, next generation molecular analysis for mutations can be done with the material from the slides. So when we first started doing rows, all those tumor cells on the slide were just nothing you could do with them. Not anymore. They are literally removed now and analyzed. So when they have 2 slides that have over 1,000 cells present, we're done from a molecular perspective. Every other single pass is being placed into a cell block to be used for any other analysis, but more importantly, for the immunohistochemical stains to prove for, if it's truly lung cancer or not, if there's a debate. I guess the value of some of these needles that are getting better tissue for us is that and by sampling across multiple parts of the node, we're able to ensure tissue adequacy because we have the feedback immediately saying, you've got enough. We take a few more for good measure, and then we're done.
Thank you.
Thank you. Yeah.
Sir, thank you for this nice lecture. My question is, how common is core in like first 3 passes? generally, how common is the core tissue? We get core tissue, like in first 2 or 3 passes.
Almost universally. In fact, to the point where, I don't have data on this, but if my first or 2 passes are inadequate, I'm already suspicious of a fibrotic node or a node that someone, I'll give you a great example. The last 3 times that, we've taken a good pass and on rows, there's almost nothing on the slide. 2 of them were patients that I walked into the room and the fellow is telling me the history, a patient that I hadn't evaluated yet, and failed to mention that the mediastinum had been radiated in the past. So what we were sampling was a fibrotic, very destroyed. Now that changed our technique. We went then for a bigger, sharper needle, added suction, and then got at least some adequacy. Also very old sarcoidosis is one of the things. So when I'm not getting good tissue on my first 2 passes, barring, if I've seen a technique issue with the trainee, it immediately is indicative of my perspective that this is not a carcinoma we're dealing with. By definition, right, the sort of crumbly nature of tumors, the way they replace most of the node, the fact that there's sometimes even central necrosis of the node, makes sampling and proving malignancy within a lymph node a relatively straightforward process. When you watch the node on ultrasound, being all bouncy and rubbery, just like it would if you palpated a benign node, you see the same characteristics. It's actually one of the reasons I'm a fan of some of these sharper needles, because they're easier to actually truly penetrate the capsule versus squish the lymph node, especially if you're going after smaller lymph nodes. So our oncology department requires us to stage anything 6 millimeters and up in size. So the only thing that we don't sample is 5 millimeters and lower. And if it's 6 millimeters or greater, we sample it. And so we get great tissue results through that technique.
So is there no data regarding how frequent is the core with the new needle? Is there any data on that?
On how often you need the core? No, there isn't. And remember, that comes back to even the definition of core. So I'm part of several different research studies that are being done in oncology, and all of them say, we need a core with an 18-gauge needle. Anyone know of an 18-gauge needle that fits down a bronchoscope, let alone an ebiscope? So we just say to them, no problem. And so we just go sample with a 25-gauge needle, give them cores, and everybody comes back happy. Because remember, a core, anything you can visibly see that you could pick up, that's a core.
Thank you.
Yep. Thanks, everybody.
Thank you, Dr. Kyle, for an excellent presentation. So now moving away from the EBUS, we have a talk by a surgeon on a robotic lobectomy, a new addition to the armory in the lung cancer. For that, we have Dr. Bala Subramanian KR. Sir, please.
Morning, everybody. Respected chair, assistant friends. Yes. So I'll be speaking about robotic lobectomies and how robotics has changed the way we see and do surgery at present. Now, we are in the era of the technological evolution in thoracic surgery. We have been seeing the evolution of surgical instrumentation and optics over the years. Now, we have reached a stage where instead of open surgery, we are going more minimally invasive. We have the multiportal VATS, we advanced uniportal, and now we are in the robotics era. Now, going on to the history of robotic lobectomy, it is not a technology which is relatively new. Way back in 2002, Franca Melfi et al. Had actually shown this, their experience in this article with doing 5 lobectomies on the robotic platform. Now, why robotics? Why and we have options like VATS or uniportal VATS. So what are the specific advantages that a surgeon has when he goes for robotics? The 3-arm advantage. For the first time in the history of surgery, you have a surgeon who is empowered with 3 hands. Now, with 3 hands, you can do a lot more. Like you can control bleeding with a 3rd arm while operating simultaneously with the other 2. You can use a third arm as an extra retraction instrument, which becomes pretty important when you're dealing with larger tumors. Now, enhanced endorse technology, where you have instruments that are capable of movement, say, similar to your or on human hand. It's a real advancement when compared to the rigid, non-articulating VATS instruments. You tend to go ahead and do more complex procedures because you have that articulation. You have tremor-free movements, very important while operating in high-risk confined spaces, and also for the first time you have a surgeon sitting comfortably on a chair, definitely increase efficiency. Now, 3D visualization with 10x magnification allows for closer dissection. You see more precisely. You see some things that I don't have ever seen before, more closer, more precisely. You have an endoscopic camera which is under the surgeon's control, unlike in VATS where you have it under the first assistant's control. You get a more efficient operation. Superior visualization, in fact, compensates for the lack of tactile feedback. Now, superior lymph node dissection is something that is possible with robotics, and it has been shown by this article by Park et al. Showing that the lymph node counts were better, and it actually led to an upstaging by around 21%. So we know that whenever we go for our malignancy, we have the ESTS guidelines specifically defining how lymph node dissection should be done, and robotics really enhances the capability for lymph node dissection. Now, so how does robotics go stand vis-a-vis VATS? Now, there's an article by Brian E. Louis who has actually analyzed data from high volume centers from 2009 to 13, around 12,020 robotic lobectomies compared to 12,300 VATS lobectomies, where they found that robotic lobectomy is equivalent to VATS, except that the operating times were about 13 minutes more. Complications and post-operative mortality were all the same. Now, our robotic program started off in 2016. We were mentored by Robert Folio in University of Alabama. We were entered subsequently to perform around 159 robotic procedures over 3.5 years. We have done around 45 lobectomies in a cohort. And this is a 28-year-old patient who presents with recurrent hemoptysis. As you can see, a large mobile fungal ball representing an aspergilloma in the right lower lobe. And we were offer for robotics here, and the standard lateral decubitus position. We either choose the 3-port technique or the 4-port technique. Recently, we have been going towards the 3-port technique, and or the usual port positions are the 7th intercostal space with a utility position in the 9th intercostal space. So once we start off with making up ports, these are all 8 mm ports, basically stab incisions there, and if it's an SI robot, you make a 12 mm port for the camera, while if it's an XI robot, you still make an 8 mm port. So once you have your ports in position, you go ahead and do your robotic docking there, where you bring the patient cart over the patient and start to attach the arms to your ports. The long instruments are introduced for as the endoscopic camera, followed by your instruments. So all the instruments, as you can see, are pretty long, and it allows you to reach every nook and corner of the pleural cavity. So once we have the robot docked, this surgeon then moves to the robotic console in the corner of the room, and you can see a lobectomy is being performed now, and you can see how until the movements of the robotic arms are, it perfectly explains why your intercostal neuralgia is probably a bit more lower in robotics than in other modalities. Here we have the surgeon in the corner of the room on the robotic console, and you can see how the hand movements on the controls at the console are being exactly replicated by the robotic instruments inside the patient's pleural cavity. Short video of the lobectomy. We always infiltrate local anesthesia in the spaces before we introduce ports. Now we have an aspergilloma, so all these additions are expected. After pleural adhesiolysis, we go on to handle the inferior pulmonary ligament. Dissecting the inferior pulmonary ligament, if it's a malignancy, we take all the lymph nodes along the ligament, and it leads to the inferior pulmonary vein there. The vein is dissected all around in preparation for looping and stapling. So that's where the robotic instruments actually help you a lot in looping these vascular structures, because they theoretically they work as well as your fingers. The inferior pulmonary vein is being stapled off, and we go into the fissures. As your oblique fissure there, separating the lower lobe, the superior segment of lower lobe from the upper lobe, and you dissect the fissure further as if the horizontal fissure between the lower lobe and the middle lobe, which is being opened up. The aim being to locate your interlobar pulmonary artery to the lower lobe. You can see the first superior segmental branch coming into view there. So you can see it's a bit sticky there because it's inflammatory. The pathology is inflammatory. Usually if it's a malignancy, you find that the planes are far better. In interlobar lymph node dissection, it's pretty important to remove all the lymph nodes one by one, because it really helps you to loop these vascular structures if your lymph nodes are out of the way. Planes being developed under the interlobar pulmonary artery. And the interlobar pulmonary artery is looped up. And as the lower lobe pulmonary artery being stapled off. Go on to develop the oblique fissure between the upper lobe and the lower lobe. And as we go on developing the fissure with staplers, we go on to identify the lower lobe bronchus there, the bronchial artery being coagulated. The bronchus being stapled off there, and that completes the lobectomy, the bronchus being looped and stapled off, completing the lobectomy. So it's pretty important that you ask the anesthesiologist to expand the upper lobe and the middle lobe, and you have your lower lobe bronchus clamped to make sure that you have not caught any other bronchus in your stapler. And once you have the specimen free, you get that. So you can see the middle lobe bronchus quite clearly there, and you start bagging the specimen. And once you have it in that bag, it's a question of manipulating it out through your utility port. Surprisingly, large specimens can come out with a bit of manipulation through even 2.5 to 3 centimeter utility ports. Always the specimen is removed as a whole, and as you can see, it's not chopped up. It's a whole specimen, and you can see the lesion in the right lower lobe. So going on to a quick glance at that data, 45 lobectomies, age is not a particular contraindication. You can see the age ranges from 28 to 80 years, males to female ratio of 25 to 20. 4-port technique was used in the initial 10 cases. In the remaining 35 cases, we moved on to a 3-port technique. Now, the duration of procedures is around 4.5 hours, around 270 minutes. The pathology, as expected, more malignancies, 6 carcinomas there, and the inflammatory pathologies represented by bronchiectasis, aspergilloma, and tuberculosis. All types of lobectomies were done, predominantly the right upper and the left lower, and followed by the right lower lobectomies. Conversions, we had around 15% conversions, with no conversions for uncontrolled bleeding. Now, the reasons for conversions, we had 4 patients where we had technical difficulties. We had a time cutoff of 4 hours. If we were not progressing much in those 4 hours, we used to convert them. And in one case early in a series, the lobectomy specimen could not be bagged, so we had to do a small thoracotomy there. No mortality, morbidity is around 13%, no persistent air leak, and no atrial fibrillations. We had a low occluded oral effusion in 2 people who had to be re-entered with VATS. Median length of hospital stay is around 5. Probably our length of stay is a day or 2 extra, because we are pretty conservative on drainage amounts. We remove it and it's below 150 ml. Now, the future of robotics, of course, is single port robotics, where you have a 2 centimeter sub-iPhoid port. You have 4 instruments, including the endo camera, coming through a single port. You don't have to work through the intercostal spaces anymore. You are going to have a lot less or negligible intercostal neuralgia, and this is going to be the few which are in every center quite soon. So robotics has changed the established paradigms in thoracic surgery, like the interventional pulmonologists. We surgeons too have newer armamentarium at our disposal. With improved dexterity and visualization, we enable more complex procedures like a sleeve lobectomy to be performed minimally invasively. We are currently using technology to make life easier for us and for our patients. Thank you.
Excellent talk, Dr. Subramaniam. I think most of us, robotic surgery is new for us. Any questions in the audience? I think if there are no questions, we'll close the session. Thank you.
Thank you, Dr. Balasubramanian, for giving insights into the robotic lobectomy. So next, we'll be having a talk on the intersection of interventional pulmonology and palliative medicine The talk will be by Dr. Rajani Surendra Bhatt.
Good morning, everyone, and I want to first start by saying thank you to Dr. Hari and to Yashoda Hospitals for the fabulous arrangements and for giving me this opportunity to talk about a subject that's very close to my heart. I'm going to be talking today about the intersection of interventional pulmonology and palliative medicine. And before I begin, I have a question. How many palliative care physicians in this room could I have a show of hands? I see one, thank you very much. That's the WHO definition of palliative care. Palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So, I'd like a show of hands again. How many palliative care physicians in this room? I see more hands go up, and I'm very happy to see that. Thank you very much again. So there's this really interesting commentary which came up a while ago, which is about how interventional bronchoscopy is really endoscopic palliative care. And I met Dr. Dev from Singapore, and he it resonated with him. As soon as I said I'm going to be speaking about palliative medicine and intervention, he said, well, that's a lot of what we do. We do palliative care through interventions every day as interventional pulmonologists. This is Dame Cicely Saunders. She's the one person who brought in a very revolutionary concept of total pain. And that's about understanding every aspect of suffering that anyone with a chronic or terminal illness experiences, and then trying to address every aspect of that suffering to see how we may alleviate it. And she's been, she's credited with founding the palliative medicine and hospice movement. And her research, her lifelong commitment to providing high quality, comfort palliative medicine has led to the development of various institutions and the growth of palliative medicine as a field, not just as a primary palliative medicine field, but also as specialty palliative medicine. And that's the part that I'm going to approach going on with this talk. So, one of the things that I work on in my free time, besides medicine and pulmonology, is I work on death literacy. India, unlike other countries, does not rank very highly on what's called the quality of death index. I think the United Kingdom ranks the highest, but our access to palliative medicine is very limited. Less than 2% of our population has access to palliative medicine, and again, that is limited mainly to cancer care and to pain. Death is not something that's unexpected for most of us. These are the 4 roads to death that you see here. What you see as sudden death and terminal illness is just about 7% and 16% of the population. The others, which are due to progressive organ failure or frailty, makes up the rest of us who are going to see some amount of suffering. And as physicians, we are able to prognosticate and recognize when our patients need more than curative or restorative treatment. And it's really appalling that in 2020, we are providing palliative medicine only to those with terminal illness, which makes up less than 20%, just about 16 to 18% of the population. That means 80% of us may potentially see a rather slow and not very comfortable decline towards the end of our lives. The ATS has made a strong statement about changing the concepts of palliative care from the prior notions of palliative care being the part of medicine which takes over after all curative or restorative measures have failed. And we now recognize that palliative medicine and curative restorative care go hand in hand. In fact, palliative medicine goes beyond the end of life of the patient and goes on to support the patient's family through death and bereavement. When we start looking at the fields of interventional pulmonology and where the intersection of palliative medicine and interventional pulmonology lies, there's increasing attention being paid to it across the world. And we have a really nice commentary about palliative care and interventional pulmonology in the clinics by Dr. Ali. And they look at the different aspects in which interventional pulmonology can benefit patients with chronic progressive life-threatening illnesses, including lung cancer, where we have interventions addressing airway obstruction, hemoptysis, malignant pleural effusions. We look at COPD. We look at lung volume reduction that's done endoscopically. We look at bronchopleural fistulae that can be managed. And many other advanced diseases not limited to the respiratory system. When you look at cardiac, renal, and liver disease, here too we have non-malignant pleural effusions where the role of an interventional pulmonologist definitely comes into play in providing relief of suffering for a patient with a chronic progressive illness. The MD Anderson team has come up with a really interesting initiative, and that's looking at embracing technology in advanced disease. They're trying to build an illustrative set of cases to build the narrative required for the two fields to start talking to each other and collaborate more. Palliative medicine physicians tend to be averse to invasive procedures. However, we as interventional pulmonologists recognize that often the patients who benefit the most are the ones who are most severely affected. We've all seen, and there are studies that show that, for example, in central airway obstruction, the more severe the obstruction, the greater relief and the greater improvement in quality of life and relief of suffering for the patient with the central airway obstruction with tumor debulking or airway stenting. As we are noticing now with the greater advances in therapeutics, cancer too has become a chronic disease. We look at patients with stage 3, stage 4 disease who are now living longer. But they're living longer with the burden of the symptoms of the disease. And therefore, there is a need for the two specialties to communicate and collaborate to make sure that we're also offering improved quality of life along with survival for these patients. So these are the questions that we're trying to address with these narratives. When should a physician, an oncologist, or a palliative care provider, or a general pulmonologist consult interventional pulmonologists? And when should an interventional pulmonologist consult a palliative care physician in order to make the appropriate plan of care for our patients? There's various models of palliative care, as we know. There's primary palliative care or specialist palliative care. More recently, we're looking at integrated models of palliative care with palliative medicine physicians rounding in intensive care units. We've talked about an IPAL ICU model of collaborative care in intensive care units. Maybe the wave of the future, or maybe the path of the future will be an integrated palliative care with interventional pulmonology model, or an IPAL IP model. For example, you could have patients with COPD who would benefit from interventions as well as rehab, as well as the palliative medicine breathlessness support services. Trying to look at a chronic integrated palliative care model for certain patients who are going to live longer with greater burden of symptoms. We could consider joint rounds between pulmonology and between pulmonology or interventional pulmonology and the palliative care services, or adding on communication facilitators like social workers or physiotherapists or psychologists into our teams to make sure that we have a more holistic approach to the patient. This would be a different kind of an MDT for the more complex patients, where you might have ethical conundrums to deal with in offering interventions to patients. I can tell you from my experience of attending sessions with our palliative medicine colleagues, they are of immense guidance to us when we are faced with ethical dilemmas about whether to offer interventions or not. Because let's face it, they've been doing this as a specialty for 25 to 30 years, and there's a lot that we can learn from them to incorporate more into our practices to offer better care to our patients. The Critical Care Society's collaborative came up with the concept of non-beneficial treatment and choosing wisely. As we advance in the technologies that we are able to offer to our patients, it's very important that interventional pulmonology professional groups also start addressing the concepts of choosing wisely and non-beneficial treatment, and try and generate data about what really should be recommended and where we might have certain difficulties in decision making. And that's when you need the specialist palliative care consult to help us provide appropriate, timely, and value-based intervention with honest communication with our patients. I'm going to use a couple of cases to illustrate these points, and these are just some things which have, some cases that have stuck with me in the way that working collaborative with palliative medicine has really added value to the patient's life. So the first set of x-rays that you see on the upper section are a gentleman who was 54 years old with an adenoid cystic carcinoma. He had it at multiple levels, and he'd undergone various stenting procedures over a period of 3 years. This gentleman lived in Mangalore, and he used to work in the Middle East. So he would come to Bangalore every 6 months to have a repeat procedure done. He had a family to support. We worked along with this patient, understanding fully well that his disease was progressing. And as far as we could, we worked with helping him alleviate the airway obstruction with stents. But there came a point when the distal progression was such that there was no more intervention that could be offered. Now, these are multiple procedures over a span of 3 years, but when the time comes that you cannot offer any more intervention to the patient, we had already involved palliative care services. This gentleman finally moved to Mangalore, where he was taken care of by the Manipal University Palliative Medicine team, along with the pulmonology team at Manipal. And he had the satisfaction and comfort of knowing that he had achieved his professional goals with his work in the Middle East. He had taken care of his financial responsibilities, and we were able to assure that the end-of-life care was appropriate, along with adequate opioids and breathlessness support services offered to him. The other case in point is a gentleman who's about 79 years old, hard of hearing, severe emphysema, had a pneumothorax. As you can see, the lungs are really like, they're almost not there. It was a really tricky situation because at his age, offering him an intervention also came with a lot of risk. We counseled the family. We went ahead and offered interventions to the patient. We placed in an intrapleural catheter, had him with a Heimlich valve for a while. He had another pneumothorax on the other side. At that point, the family said, yes, they would be okay with proceeding on the other side as well. This gentleman underwent a pleuroscopic pleurodesis after resolution of the air leak, and he survived for another 5 years after that until he passed away about 2 years ago with an intracranial bleed. But in that much time, we were able to offer great quality of life. This is the kind of patient who very often, if they went only to a palliative medicine or very often people don't offer interventions to such patients. However, with the right kind of counseling and selection of patients, we can offer interventions with a great improvement in quality of life. This is also a conversation piece that's been noticed by other interventional pulmonologists across the world. We talk about a culture of bronchoscopy, which really is about understanding the patient's needs and providing that holistic care to the patient, understanding what their psychological needs are when they have severe problems like breathlessness. And maybe there is a niche field that's there for interventional pulmonologists who are interested in applying palliative medicine principles and developing that agenda a little further. There's challenges and pitfalls, obviously, along the road. Sometimes we wonder, and we say that, interventional pulmonology already is a long path. Most of us have spent many, many years getting here, going through internal medicine, pulmonary critical care intervention training. And there is a misconception that palliative medicine is another burden on us, it's time-consuming. However, I can tell you that very often, the stories that we carry with us are the patients who we are not able to help. And a little bit of collaboration with our palliative medicine colleagues and incorporating their training principles into our training principles might provide us with greater skills to handle the challenges of our work, communicate better with our patients. And that also has a positive effect for us with reducing burnout in our field. As we know, pulmonology, intervention, critical care are all high burnout fields. And having the input and training from the palliative medicine professionals or a collaborative approach can help us even safeguard our own health and long-term viability. The American College of Surgeons has launched an initiative which is about palliative surgery and surgical palliative care. And though this is more applicable to surgical oncology, I find it interesting that the surgeons seem to be taking a lead here in applying palliative medicine principles to their training programs. And we're also seeing critical care societies and the pulmonary critical care community coming together to make statements about the need for incorporating palliative medicine principles in our training. I think it's a natural extension that palliative medicine training becomes part of upskilling ourselves as interventional pulmonologists as well. So we've been looking at developing a palliative pulmonology research agenda and training agenda in India, and increasingly our national meetings and conferences have included topics which sensitize our students and our colleagues and peers about the need for developing more training programs which incorporate palliative medicine principles, as well as measuring the outcomes in terms of quality of life improvement on patients when we have a collaborative approach with pulmonology and palliative medicine. There have been a few books that came out in the last few years which had a great impact on the social consciousness. When Breath Becomes Air by a neurosurgeon, a young man in his 30s, faced with stage 4 malignancy, was one. Being Mortal by Atul Gawande was another. And the conversation is shifting to patients being more aware of the kind of care they would like and that can be provided to them. And it is only fitting that we rise up to the challenge to offer our patients the highest quality of care, including palliative medicine, along with the interventions that we offer. I'm going to finish with a story of a patient who was very dear to me. A young man, 33 years old, with a history of a malignancy. He had a laryngeal malignancy 8 years ago and had undergone a total laryngectomy. He was a former sportsman, and then he turned to be a cricket writer. He developed hemoptysis and found that there was a return of his malignancy. He had a metastatic synovial sarcoma, which recurred in 2017, underwent embolization. Subsequently, he went in for surgery. All his therapies really did not help him. The tumor progressed. In August of 2018, he had progressive disease and presented with massive hemoptysis. His oncologist said that they've exhausted almost all treatment options. He was currently on immunotherapy, and he was going to be tried on the next line of treatment, but they really didn't know how much longer they would be able to give him. This patient, you know, it's quite an emotional thing when you're in the emergency room and you have someone who has rivers of blood coming out of his stoma and, you know, sheer fear in his eyes, and he looks at you and says that, "I need you to buy me 4 days, doc." And I asked him what he wanted with those 4 days, and he said, "I have unfinished business. There's a book that I'm writing that I need to complete. My daughter's birthday is in a few days, and I'd like to see her on her birthday." So we had an honest heart-to-heart. We went ahead with a bronchoscopy, and we went ahead and did a glue installation at that point. And following that, he had a rebleed, but you know, we told him that this could potentially be a procedure which may or may not reverse the course of his disease. I'm just going to play a brief video of what was offered for him. He underwent a glue installation first, large clots continued, he had a spigot placed, and subsequently after that, he was ventilated during this time. Subsequently after that, we were able to extubate him, and he went on to complete his book. He went on to celebrate his daughter's 4th birthday with her, and he also managed to take her to see a cricket match for the very first time. This gentleman got 9 more months. He underwent another procedure for a rebleed. His book was released, and it's now one of the contenders for the crossword bestsellers, for the best books in a certain, in the segment of sports writing or nonfiction. So it's really been a moving journey to hold some patients' hands and try and help them achieve their goals. And this is what we mean when we're looking at suffering as not just physical. You need to try and help the patient achieve their goals of, professional fulfillment, psychosocial stability, as well as being able to achieve the family's goals together. Last year, I had the wonderful opportunity of actually visiting the Dame Cicely Saunders Center to get a little bit more training in pulmonary palliative care. And I can only tell you that, the experience has been so enriching. To be able to go and speak at what is considered the Mecca of palliative medicine was a great experience. And to see the collaborative spirit of pulmonology and palliative medicine at King's College was really a wonderful experience. I'm very happy to say that similar movements are taking place across our country as well. At the All India Institute of Medical Sciences, the palliative medicine residents rotate along with the pulmonology team, therefore providing a different perspective to the pulmonology residents, and they are also empowered to trigger palliative medicine consults. So the pulmonology residents, as well as the palliative medicine residents, benefit from this interaction with each other on the same patients. The Manipal Academy of Higher Education and Kasturba Medical College has a similar model where the palliative medicine team rounds along with the pulmonology, intensive care, cardiology, neurology, nephrology, oncology, and pediatric teams, therefore providing comprehensive palliative medicine, not just to patients with malignancies or with pain, but for non-malignant disease as well. We've now started a collaboration between pulmonologists and palliative medicine specialists from across the country. In December, a group of us met, 10 pulmonologists and 10 palliative medicine physicians, to start framing statements about how we would like training programs to now incorporate principles of palliative medicine in every specialty so that we now address the issues of suffering and improving quality of life for all patients, not just those who have malignancy or pain, but address the end-of-life care and quality of care for all patients across the board. Thank you very much for your patient listening.
Thank you for a very interesting talk, Dr. Rajani. I really like the way that you portray how we can actually integrate palliative and also interventional part of pulmonology. One question from me, how do you overcome the challenges that you face? Usually when patient already opted for palliative care, they probably will not be expecting any interventional procedures to be done on them. So how do you convince this kind of patient, palliative patient, to still receive interventional care? Thank you.
I think that's a wonderful question. I will say that in India, less than 2% of patients, as I said, have access to palliative care. So very often, patients are referred to us directly by their physicians or oncologists. And in these situations, it's really more about our judgment whether the intervention is appropriate or not. For example, you could have a patient with a pleural effusion. That patient has a malignancy. However, their primary complaint is not breathlessness and it's pain. And putting an indwelling pleural catheter may not be the best approach there, but actually using a nerve block for pain alleviation might be the better approach. I often find that unless we are trained in addressing these principles, we are quick to jump to offering solutions. So this is where interventional pulmonologists need to understand the palliative concepts. I think inviting and collaborating with our palliative medicine colleagues would be the ideal way. So now we have interventional pulmonologists in, for example, when you look at MD Anderson or Tata Memorial Hospital, which are the large cancer hospitals, these are the places where the palliative medicine people are getting more and more aware of the fact that intervention actually improves quality of life. So I think it will require a continued dialogue. When it comes to patients, I think honest conversation by picking up the phone with the palliative medicine doctor and telling them that these are the risks and benefits that we can offer is the ideal way to go.
Thank you. Any other question from the audience? If there is, okay, yeah.
Thank you, ma'am. I have just a nice lecture. I have just one comment regarding the palliative care. Like, would we give the painkillers in the maximum OPI dose does not give the patient the relief. So there comes the role of interventional pulmonology or even the other, like the patient has a chest wall pain. Maximum OPI does not help. So we have to have an alternative for that.
Yeah.
Like we have a endosurgical or like laser or something. That's very important.
Absolutely. I think that this is where it's really important that we work in a collaborative fashion. What the example that you mentioned is really about looking at your pain management services and looking at interventions that can be, so interventions are not necessarily just pulmonology interventions, but palliative medicine doctors, if they're aware of all the possible interventions. When you look at cardiology, for example, when you look at chronic end-stage heart failure, CRT itself is one of those interventions which can help in improving quality of life in those patients. But if the palliative medicine doctor is not aware of that, they may not look at offering interventions to the patient. So we do need greater dialogue between all specialties. Thank you. Thank you.
So that brings to the end of the first session. So May I request Dr. Jamalul Aziz to kindly come over to the stage to felicitate our speakers and the moderators. I would like to request the moderators to join Dr. Jamalul Aziz. Dr. Vishwanath Gella. Dr. Devanand. Dr. Kylie Hogarth. Dr. Balasubramanian. Dr. Rajni Surendra Bhatt. I kindly request Dr. Jamalul Aziz to felicitate our moderators, Dr. Sudhir Prasad. Dr. Chaitanya Deepak. And Dr. Narul Yaqeen. Thank you, sir. So we will be moving to the second session. The session is on interventional pulmonology in tuberculosis and sarcoidosis. To moderate this session, we have Dr. N.H. Krishna, Dr. Subhakar Kandi, and Dr. Mahbub Khan. Sir, please come on to the stage, please. And to start off with this session, we have none other than Dr. Jamsak from Thailand to speak on the TB, tracheobronchial stenosis, and overview. Sir, please.
Okay, good morning. First, I would like to thank the organizing committees for their kind invitations for me to talk on this topic. So our talk will be an overview, as the topic said. So I will start with the definitions. The definitions of the endobronchial tuberculosis is that you have to have the histological examinations of the lesions endoscopically that show granulomatous inflammations with caseation necrosis or positive acid-fast bacilli on cultures or from the sections. Its prevalence is around 10 to 40% of all pulmonary tuberculosis. And surprisingly, the cause is very variable, so make you hard to make a diagnosis clinically. And this is just a pathologist that you can see the granuloma with special cells. And the pathogenesis is either the direct spread of the tubercle bacilli from parenchymal tuberculosis, which has a high abundance of tuberculosis bacilli like in cavitary lesions, or disseminations of tubercle bacilli from peribronchial lymphatic channels that drains the lymph to the lymph node in mediastinums, or either the ruptures of the nodes beneath the trachea or beneath the bronchi to go into the endobronchially. Or it's made directly implants of the inhaled Mycobacterium tuberculosis into the bronchial wall mucosa. You have to divide the disease into active disease, which is the, you can demonstrate active caseation material, ulceration, granulation, tissue formation, with demonstrated the positive tubercle bacilli on the cultures, and a fibrotic stage or fibrotic disease, which only you see the fibrosis endoscopically, and you cannot find the tubercle or the bacteria. Left main bronchus is most frequently involved, as you know. Maybe it's because of anatomical compressed by the aortic arch, maybe it's longer than the right side, or maybe the left mediastinal lymph node infected faster than the right side. To make a diagnosis, clinically, we know that a female has more prevalence on this disease than male. Patients may come with the coughing, losing weight, hemoptysis, chest pain, or dyspnea. It's a commonly coincidence with the parenchymal disease. It happens in your second or third decade of life, and it has a misdiagnosis of asthma wheezings because of the wheezings. Sputum positive AFB in around 13 to 50%, and tuberculin skin test positive in 59%. If you do the IGRA test, it's only sensitive in 64 to 92%. If the patients have upper airway involvement, it means tracheal involvement, the lesions need to be less than 8 millimeters of the lumens before symptoms happens. And at that time, the peak flow will decrease to 40%, resistance increase to 600%, with moderate exercise limitations, and the FEV1s decrease to 75% predicted. So, lung function test is a very late diagnosis on this disease. Also, the chest X-ray may show a normal in 10%. Mostly it shows pulmonary infiltrations. 60% of the patients show parenchymal infiltrations, with 24% show losing the lung volumes. 8% show a normal chest X-ray. Patients may come in with the post-obstruction pneumonia, atelectasis. CT scans can show you where the lesion is and the extent of the lesions. And it can differentiate active from the fibrotic stage by seeing the wall of the airways, which if it's swelling, it means it's likely to be the active one. Bronchoscopically view, Dr. Chung separated the endobronchial lesions into the active caseatings, the edematous hyperemic, the fibrotic, and the tumorous. All four characters can have a high chance to go to the obstructive lesions after we treat. If the lesions turn out to be a granular, ulcerative, or non-specific bronchitis, it has a low chance to go to the fibrotic stage later. So this is just a tumorous stage. It's caused by the direct extensions of the submucosal lymph node. And this is the granular and the fibrotic stage. This is a non-specific bronchitis that causes some obstruction. The management, mainly of the management of endobronchial tuberculosis, is to eradicate the tubercle bacilli. And the prevention of the most undesirable consequence, which is stenosis. There are studies said that you can have persistent bronchostenosis in 41% of the disease, especially if the age of the patients more than 45 years old, if you had a pure or combined fibrostenotic subtypes when you saw him, if the durations from the onset of the shift complaints to antituberculous treatments more than 3 months. And this is already been said that if you see endobronchially the characters of the involvement, you have a high chance if you have that's first 4 findings. And this also, they find out that endobronchial lesion can change, and it doesn't matter what you saw that will predict the outcome. If it is the active stage, you have to control infections and prevent bronchial stenosis. And we all know that corticosteroid does not help in this situation. If the patients come in with a fibrotic stage, medical treatment has no benefits. Antituberculous chemotherapies more than 3 months in the patients with airway involvement will predict the persistent airway stenosis. Means you cannot predict the patients whether they will go to the airway stenosis or not before 3 months of treatment. So usually if you are suspicious that patients should have endobronchial tuberculosis, you can do a surveillance endoscopically. And if the patient has symptoms, you can do balloon-tation, stents, lasers, argon plasma correction, cryotherapy, or if you have endobronchial ultrasound, you can early predict it whether the patients will go for bronchostenotic type to evaluate the underlying cartilaginous structures. If the patient doesn't have cartilages, they can easily go to the bronchostenotic type. Iwamoto, maybe nearly 20 years ago, he reported 30 patients. In these 30 patients, 12 patients continue to have dyspnea after treatment. In these 12 patients, 1 patient needs pneumonectomy, 6 patients, he had to put a stent in. In these 6 patients, on the rest, in 5 patients, repeat balloon dilatations only, the symptoms is improving. So balloon dilatation alone is sufficient in 30 to 40%. Also, I said about the radial EBUS, whether you have it or not, it will help you earlier time. The airway stents, they suggest a silicone stent because, as you know, we can easily remove it after the patient's getting better. Another series, he follows 80 patients, and the only things that I can tell you, the story is the same. You try balloon dilatations first, and if it's work, it's work. If it's not work, you can put a stent in, and then you wait for some time, and then you try to remove the stent, and you will get a success. As you see, there are some patients that you cannot remove the stent at all. So the decisions to put the stent in during the active phase of the disease is very mandatory. So this is another series. We only have a case series here in endobronchial tuberculosis management. There are no comparable studies in this kind of disease because of the rarity. In these studies, he reported in 7-year experience, 7 patients, and he had 11 dilatations, 10 stents put in with 1 wide stent, which mean durations of 32 months, 1 pneumothorax, 2 stents migrations with no mortalities. They cannot come up with no durations of stent guideline. And they suggest attempt to remove stent in 8 to 16 months. And this is the latest report from Jiu Li from China suggested repeated bronchoscopic balloon dilatations in non-malignant. Non-malignant central airway obstruction in this series mostly is endobronchial tuberculosis. So this study came out that around 5 times repeated balloon dilatations, it's still working in this kind of disease. This is an example of patients who came in with total left lung atelectasis, and after opening to put a stent in, you can see the re-expansion with some upper lobes still have atelectasis in the disease. So my conclusions and practical points is that this disease is very difficult to diagnose. You can suspect it if the patients who had tuberculosis came in with unproportionated cough. They cough a lot, but they have so little lesions on the chest X-ray, or came in with a dyspnea, and you can hear the bronchitis. If the patients had an active phase with no symptoms, conservative treatment is mandatory. And the lung function should be done after the complete treatment and bronchoscopy if indicated. If the patient in active phase come in with the symptoms, then you have to do bronchoscopy. You have to prove whether it's active phase and whether the patients need balloon dilatations or stent is controversies. If patients come in with fibrotic phase with no symptoms and lung function impaired, whether you have to do interventions is still, we don't know. It depends on how much impairments of the lung function the patient has, because they have no symptoms. If the patients came in with the symptoms, we do a bronchoscopy, we prove that this is not the active phase, and then we choose the interventions management. If you can see no lumens endoscopically, I suggest to consult the surgeons to do a bronchoplasty. If you find the single lesions endoscopically, so you can do a bronchoscopically interventions or surgical corrections. It depends on the patients, on the discussions, on whether you have a good surgeons to do the bronchoplasty or not. But if the complex lesion, it means only bronchoscopic interventions is available. The complex lesions mean if you had more than 2 lesions or 1 lesions that the length is more than 2 centimeters. And that's all I have to say. Thank you.
Thank you, Jamsak, for that lucid presentation on the management of the tracheobronchial stenosis, particularly tuberculous tracheobronchial stenosis, which is the most relevant in the part of this country. We have 1/4 of the global TB burden in India. In fact, most of these cases, because having worked in a tertiary care institute for more than 25 years in the TB, we have seen most of these cases being misdiagnosed as asthma, and some cases were diagnosed as lung cancer. They have referred to us. So the advent of the interventional pulmonology, it was made easy to diagnose these cases, of course, and not only diagnose, a lot of therapeutic interventions also. I invite if there are any questions from the audience to Dr. Jamasak, 1 or 2 questions. If there are no questions, I have one question regarding the role of steroids in the endobronchial tuberculosis. You said there is no role of steroids, I think we have presented in one of the slides. This was no role in stenosis or as a whole in the endobronchial tuberculosis? Because one of the standard saying is there is a role of steroids in endobronchial tuberculosis. But if already the stenosis has happened, of course, there may not be any role. I want to hear from you.
Okay, what I say that is because there are no randomized control trial on steroids in endobronchial tuberculosis. And also, there are no anecdotal report that the benefit of the steroids we have in endobronchial tuberculosis. What we applied and what the people who love steroids said is just some evidence in the non-tuberculous endobronchial benign stenosis, like in post endotracheal tube tracheal stenosis, and they have a report of the injection of the steroid submucosally may help, but my personal experience is that we try all.
Because in India,
it's not work.
In India, we give steroids in endobronch. In fact, I attended yesterday one session on the rigid bronchoscopy. They have shown some cases presenting as a growth, ultimately diagnosed by biopsy, and they have given a 2 months course of intensive phase. After the intensive phase, along with the steroids, then only you do an intervention if there is an activity of the disease.
Thank you. We're going to need a randomized control trial.
If there are no questions, we'll go for the next talk. I request.
Hello, sir.
Thank you.
I think.
So thanks, Dr. Jamsek, for the wonderful
Do you have
explanation.
time for one question?
Thanks
Yeah,
for
only that will be the last question.
Thanks for that wonderful presentation on TB stenosis, actually, sir. Now, can you just enumerate between the left main stenosis and the right main stenosis? What are the differences?
Dr. Sunil, you are not audible. You are not audible.
Is it okay now?
Yeah, fine.
Thanks for the wonderful presentation on TB stenosis, actually, sir. I just want, what are the tips on left main stenosis and the right main stenosis? What is your usual take on how do you approach your left main and right main? Any difference when it comes to especially left main bronchial stenosis?
The question is whether there is a difference in the approach if there is a left main bronchial stenosis or right main bronchial stenosis.
Oh, sure. Because the right main is shorter, easier for you to open it out. And the left main is longer, and you don't know actually how long the stenotic is, except that you have the history and the CT scan before, or you have examined it before it's closed. So the length of the stenosis, when it's totally collapsed, it's related to the risk that you will penetrate the wall of the airways, right? So right main is quite more easier, but most of the time you will lose the right upper lobes because of the short segments of the right main. So usually the stenosis involve the right upper lobe also. So yeah, if you're the IP doctors and doing the dilatations of the endobronchial tuberculosis, you will love right main. But unfortunately, left main is more prevalent than right main.
Thank you.
Thank you. Thank you, sir.
Thank you, Dr. Jamshak, for an excellent presentation on tracheobronchial stenosis by TB. Next, in the series of talks on TB, we have a talk by Dr. Vaju on TB stenosis, a case-based learning.
Good afternoon. Thank you for inviting me to this distinguished conference, and thank you for all here. I'm Dr. Wahyu Animedianingsih from Jakarta, Indonesia. I will talk about endobronchial tuberculosis, especially in TB stenosis in main airways. Indonesia, as all we know, that still have high cases of the tuberculosis. So it's number 2 in the world right now. And we do know that central airway stenosis, if not treated carefully and very, very promptly, it will cause a lot of morbidity and mortality. And surely it will take a multidisciplinary approach, either in interventional pulmonologists, anesthesiologists who will be in the team, a thoracic surgeon, a radiologist, and all the nurses who were capable to help us in the intervention. Endobronchial tuberculosis, it's tuberculosis which affect the tracheobronchial tree, and it presents also in 10 until 12% in patients with normal chest X-ray, and active pulmonary tuberculosis, it's seen about 10 to 40% of active pulmonary tuberculosis. We don't know yet why, but the most of the patient that we encounter in our daily practices is young female. So endobronchial TB can cause complications such as tracheobronchostenosis if we give anti-tuberculosis treatment, but it still will cause some problems such as stenosis. And it's just Dr. Jamsak said that it can mistaken and delayed diagnosis due to unspecific symptoms such as asthma. So it still can develop also after the anti-tuberculosis is complete. We gave anti-tuberculosis treatment in Indonesia for the endobronchial TB cases. We treat them as extra pulmonary tuberculosis, so minimum 12 months. So the pathogenesis is the same as Dr. Jamsak says, and predilection, we don't know why it's most affected subjects is young female. So it's hepatitis that women do not expect to read sputum, possibly of their sociocultural factors. So its classification that was published in CHEST in 2000, Chung classification. So until now, corticosteroids still controversies. So in children, we can give them and it can reduce the bronchial obstruction to hilar lymphadenopathy, but not in adults. And it could not reverse the fibrosis. Why? Like in asthma and COPD, we observe also remodeling in tuberculosis. But remodeling in tuberculosis is an inappropriate response to lung injury, such as residual cavitation, fibrosis, cicatrix, loss of normal lung architectures that will alter the extensive fibrosis, include airway fibrosis leading to airway stenosis. It's hypothesized also in Journal of Infectious Disease. It's because the failed Th1 mediated immunity and cause Th2-like immunity. So the role of giving the anti-inflammatory drugs is still ongoing research. I will give, because this is case-based illustration, I will give some cases that was found in our practice. This is a simple central airway obstruction, female, 60 years old, post-tuberculosis treatment, who has dyspnea, stridor, and impending respiratory failure. We see this in this patient. We have pinpoint stenosis due to tuberculosis in mid-trachea. Because it's only less than 1 centimeter, we can dilate with the rigid scope, and we put stent afterwards. And after 3 or 6 months, we put out the stent, and the lumen was achieved normally. This is a long, complicated stenosis. The patient was complaining of short of breathness after the start of the tuberculosis treatment. And in CT scan, we can see there's a long complicated stenosis. So in this patient, we see very complicated stenosis. Patient has stridor, sometimes cyanotic, and bronchoscopy pre-intervention. We found stenosis just below the vocal cord and down along to the carina and the right main bronchus. You see there is a tumorous-like also in the 2 centimeters above the carina and in front of the right main bronchus. So this is after post-dilatation. The patient underwent several dilatation with rigid scope. With time sparse is 2 weeks, and afterwards 1 month, 3 months, and 6 months. This is also the long complicated airway stenosis. The patient had suffered cyanosis, stridor, and dyspnea. We can see there's ischiatus lesion in this patient, along of the trachea down to the carina. And we do the rigid dilatation, starting from the smallest diameter of the rigid scope, and then to the larger diameter of the rigid bronchoscopes. This is another story of the complicated long airway stenosis. The patient, female, again, 24 years old, who had worsening dyspnea. She had been treated anti-tuberculosis drug for 4 months. Here, after 4 months, the lesion in the chest X-ray is better, but the patient complains more and more breathlessness. In the CT, there is we see complicated stenosis, and then we try to do intervention with bronchoscopic procedures, but we failed because of the stiffness of the trachea. And then with our colleague of thoracic surgeon, we do tracheoplasty, and the tracheal wall is incised and then being covered by pericardial patch, and then we put the silastic stent inside the pericardial patch. But because of the patient just started about 4 months anti-tuberculosis drugs, the stenosis reoccurred. Although we do a lot of interventions such as mitomycin application, injection of corticosteroid intralesion, the patient keep worsening and keep getting worse, and the patient died. This is the case number, the next case, the patient this is a male, 50 years old with worsening dyspnea. And we see there is a mass, mediastinal mass, and in bronchoscopic, the movie is not moving, we found a mass obstructing the distal trachea. The frozen section said that it was TB, and then we put Y stent. This is the bronchoscopic appearance after the Y stent placement. This is a TB stenosis male, 29 years old, who has referred from other city to our hospital. This is, he had very, very severe dyspnea, And we found pinpoint stenosis just 2 centimeters below the vocal cords. And we do balloon dilatation, and we continue with the bronchoscopic rigid dilatation, starting with the smallest one, and then we continue to larger bronchoscopic tubes. And then after the second intervention and last observation, the patient had no symptoms, and he didn't complain any dyspnea, and the quality of life is very good. I forgot to mention, in all of the patients, most of them, we give, beside anti-tuberculosis treatment, we also give them Labax, inhaled Labax, to reduce the inflammation. This is our words for MDR tuberculosis or XDR tuberculosis patient. This is how we do bronchoscopy in patients with MDR and XDR tuberculosis. So we have also the patient with TB stenosis in MDR TB patient. We do balloon dilatation and same with the rigid scope dilatation, buccination. And then the patient was given MDR TB drugs, and now the patient, and also Labax, and the patient outcome is quite good. So this is the tracheal TB patient, female, 25 years old, endobronchial TB. After completed treatment, there is a collapse in the right lung. But in the bronchoscopy, there is a little hole in the right main bronchus, and the thoracic surgeon did bronchoplasty with the pericardial patch, and it is the patient was good condition. The lung expanded until now, and we were very happy for this patient. This some of the patient with surgical repair tracheobronchial TB cases with stent-supported patch or only pericardial patch. What will happen with the patch if we remove the supporting patch? This is how it looks, the bronchoscopic appearance after 2 years removal of the stent. Sometimes we didn't do anything. If we don't see a hole or any more distant airway after the stenosis, we didn't do anything because it will give the patient more risk to do procedures besides to do nothing. So this is also the patient, 20 years old. She came after 6-month tuberculosis treatment, and she had a collapse, full collapse of the right lungs. And then in bronchoscopy, we didn't see any hole in the right main bronchus. It completely obstructed, so we did not do anything for this patient. This is tumorous-like tuberculosis. The patient was treated because of hemoptysis at first, and after 2 months, she complained of breathlessness. And when we see this CT scan, we see a mass in the intermediate truncus intermediate, and this is the bronchoscopic appearance. It looks like that it is lymph nodes getting in the airways. So we didn't do anything for this patient. We just continue the anti-tuberculosis treatment along with Labax, and the patient was resolved, and then the result is quite good. So endobronchial TB leading tracheobronchial stenosis is a complex problem. The question remains that should we do bronchoscopy as routine procedure for all pulmonary tuberculosis or not? The role of corticosteroid, and should we do, how long we do follow-up bronchoscopy in this patient. Still, we need to do more research on this, and of course, a guideline is needed. Thank you.
Thank you, Dr. Waju. It was a very good case-based learning, IP. I could see that you did a good job in most of the cases which you presented us here. My question is, you are here since yesterday, and you must have also seen the interventional pulmonology happening in India, and how you think, how it's different, and what do you think the difference in Indonesia, what you do across in the IP for the post-tuberculosis cases, and here, you see any differences? What do they do here and what you do in Indonesia?
I think it's more or like the same. Depend of the kind of the stenosis we see and how long the tuberculosis treatment has been given, or it's just treated or it's delayed. That depends a lot of things.
Thank you.
Thank you.
Any questions? Yes, go ahead.
Hi, so how long do you have anti-tuberculosis therapy on before you offer surgical intervention for tracheobronchial stenosis?
I'm sorry.
I think before intervening, how long you are going to give the medical treatment before intervening?
How long? If the patient in severe dyspnea, we do right away the procedure of the intervention, but along with the tuberculosis treatment and Labax, inhaled Labax.
The Indian guideline says the patient should complete at least the intensive phase, because when the sputum is positive, it is a basal case, it will be risk for the operator as well as the patient also. So what you see is till it completes the intensive phase, we wait. Once the smear is converted, we do go for the intervention.
But in the patient with the respiratory distress, we cannot wait until the conversion of the anti-tuberculosis.
Of course, emergency you can't get.
Yes.
This is emergency.
Yes.
One more question, sir.
That will be the last question.
Yes. Thank you, ma'am. Great cases. So you have told corticosteroids have there is a doubtful role about these steroids in tracheobronchial stenosis. I want to know from your experience, do you usually prefer giving either nebulized or oral corticosteroids to these patients?
Yes, inhaled LABA and inhaled corticosteroids, because in the LABA there is a component of the anti-inflammatory effects for the patient, like in the slides, because it was hypothesized that is Th2-like immunity that take over in the endobronchial stenosis.
So you give them as a routine, on a routine follow-up for these patients?
Yes, in the patient with the endobronchial TB, along with anti-tuberculosis treatment.
I've been going through a concept of nebulized anti-tuberculous drugs being given as a dry powder inhalers. So any comment on that? So in future we can expect such kind of treatment for?
Yes, it still need further study, I think. Maybe when we need to complete a national registry to see whether it giving anti-inflammatory drugs really give the patient any difference.
Okay,
I think that answered it. We are running out of time. Thank you, Waju. That was a very good presentation.
Thank you.
Next speaker, please.
Thank you. Thank you, Dr. Waju, for your talk. So now moving away from the pulmonologist, here we have a surgeon, thoracic surgeon, to speak beyond interventional pulmonology, the surgery in TB, tracheobronchial stenosis. For this, we have Dr. Mohan from Gangaram.
Thank you so much. At this outset, I would like to thank Dr. Harikishan and the team Yashoda for giving me this great opportunity. My role is to explain the role of surgery and discuss the options of surgery in tubercular tracheobronchial stenosis. Greetings from Sir Gangaram Hospital, the premier institute from Delhi, and Center for Chest Surgery. This is our team. We are 5 consultants and 6 residents, a team of 11 dedicated thoracic surgeons from under a single umbrella. So tubercular infections. So in the next 15 minutes, I will be taking you through an exciting journey of the role of surgery in tubercular tracheobronchial stenosis. Sit back, relax, and enjoy the ride. So tubercular chest infections can involve the parenchyma, pleura, mediastinum, chest wall, as well as the tracheobronchial. So I will be discussing the part of tracheal and bronchial strictures in tuberculosis. This paper has been quoted by the previous 2 speakers. This paper described 7 types of endobronchial tuberculosis, and these are the various bronchoscopic pictures. And this is the end result after 7 years of follow-up. You can see here 34 patients of caseating endobronchial, around 22 patients have developed fibrostenosis at the end. Out of 11 patients of edematous hyperemic, around 7 patients have developed the stenosis. Out of the 11 granular, 2 patients developed. So many of these major contribution of these patients ended up in having the fibrostenosis. The $1,000,000 question is, what is the role of the surgeon? Why surgery is required and when surgery is required? So why surgery is required? Let's go through this. It's a illustration where the various modalities and the treatment of stenosis. The anti-tuberculous therapy, the corticosteroids have no role in treating this stenosis. However, the bronchoscopic interventions, yes, it has a role, but it is temporary. And surgical intervention will give you the permanent solution for this problem if it is actually required. So what are the flaws with the bronchoscopic intervention? There are several interventions have been described: balloon dilatation, stent placement, laser photocoagulation, argon plasma coagulation, cryotherapy. There are many types of bronchoscopic intervention have been described. So, however, the protocols are not standardized till now. They are managed on case-to-case basis. The patient requires multiple times interventions, repeated hospital visits, repeated admissions. However, in stents, if the patient is on stent, this stent is not without its side effects. It will lead to persistent cough, mucus plugging, migration, granulation tissue, and many more other problems or complications that can occur. And however, the duration of stent placement is not clear. So there are many flaws or problems with this bronchoscopic intervention. So then comes, I am not going to discuss the theoretical part of the surgical indications. So I am directly going to the routine clinical scenarios we see in the day-to-day picture. So I have divided the indications into 5 subcategories. One is the tracheal stenosis. Next is the cricotracheal stenosis. Third is a main bronchostenosis which completely destroyed the ipsilateral lung, and the lobar bronchostenosis with a destroyed lobe itself, and the main bronchostenosis with preserved lung parenchyma. I will go through each and every subtopic and I will share our experience with the same. However, there are several prerequisites for the surgery. The patient should have taken 3 to 6 months of ATT. There should be no evidence of active tuberculosis when we are operating for the surgery, when operating the patient, because it will lead to the higher chances of bronchopleural fistula if there is active tuberculosis. And the patient should have underwent many bronchoscopic interventions and they are ineffective. At this stage, the role of surgery comes. Especially in case of tracheal stenosis, if we want to resect the stenosis, we cannot resect more than 50% of the trachea. Suppose if the length of the trachea is around 10 centimeters, we cannot resect more than 5 centimeters of trachea. And of course, the patient should be fit enough to undergo the surgery. So coming to the principles of the surgery, the patient should be control regarding all his underlying risk factors. The patient is hypertensive, diabetic, multiple comorbidities. They have to be controlled before the surgery. The patient should be built up nutritionally. We routinely place the nasogastric tube for these patients, feed them for 7 to 10 days. They're all malnourished. We'll give 7 to 10 days of this nutrition, build up them, take the albumin to the 3, more than 3, and then we operate these patients. However, the mode of surgery depends on the location, the extent, and the degree of the stenosis. The role main, the funda of the surgery is to preserve the lung parenchyma if it is possible, as far as possible. And we have to achieve the macroscopically clear margins. That is, that we have to achieve the anastomosis between the healthy mucosa to healthy mucosa, so that there are no re-stenosis that will develop after the surgery. And we try to cover the anastomosis with the autologous tissue. So this is how we do the preoperative evaluation. We do always the CT with 3D neck reconstruction. This is an illustrative picture you can see here. We will see the total length of the trachea, where is the stenosis is present, and what is the distance of the stenosis from the cricoid, what is the distance from the carina, and what is the status of the cricoid. If the cricoid involved is a very, very complex issue, and yesterday we have presented a video, and I will reinforce that now. And we'll do the preoperative bronchoscopy ourselves. Our star bronchoscopist is here, Dr. Amit Damija. We always work as a team with him. We always do the bronchoscopy on him. We assess these parameters, the location, the shape, the length, the severity of the obstruction, the distance from the anatomical structures, the type of strictures, the components, associated abnormalities, the distal malacia is there or not, what is the status of the distal airways. So these are the various components we actually evaluate during the bronchoscopy, and then we assess for the surgery. So coming to the clinical scenarios, I'm going to the tracheal stenosis. So this is a patient with mid-tracheal stenosis. Due to the severity of the stenosis, the patient was tracheostomized earlier. At this point of time, he was referred to us. If the patient is tracheostomized, during the surgery, we will induce the patient through the tracheostomy. However, if the patient is not tracheostomized, but there is a critical stenosis, the minimum diameter is 5 to 6 mm. The patient, we actually intubate the patient in awake intubation. The patients are fully conscious. You can see both of these young patients are fully conscious, and nasotracheal intubation was done. How we do it? We do intubation over the bronchoscope. We pass a small caliber bronchoscope through the nasal route into the trachea. You can see the stenosis here. We bypass the stenosis. We enter into the distal trachea, and over which we push the bronchoscope to the distal to the stenosis. This is how we intubate in our patients. And this is the concept of tube over tube that we follow, where because the stenosis is 5 to 6 mm, the innermost diameter is 5 to 6 mm, we have to put the pediatric tubes, 3.5, 4 tubes we have, endotracheal tube we have to put. Since it's a nasotracheal route, we have to get enough length of the tube. To gain the extra length of the tube, we will put a tube over tube so that we can get extra length, and then this is, we can get the extra length. This is how my colleague is doing the nasotracheal intubation. So this is the surgical video of how we do the stenosis surgery. So this is the preoperative bronchoscopy. This is the preoperative CT, where you can see the tracheal stenosis. The patient is already tracheostomized. So there are dense adhesions around there will be dense adhesions around the tracheostomy site. So our intention is to lyse all the adhesions surrounding the trachea, to reach the tracheal wall in the midline. So after reaching the tracheal wall, these are the two maneuvers that we do. This is mediastinal mobilization of trachea, because to gain extra length of the trachea, we have to do several maneuvers to gain the extra length. One thing is the mediastinal mobilization that you have seen, and this is the laryngeal drop. Supra as well as infra had laryngeal drop. We'll gain approximately 2 to 3 centimeters of greater mobilization of trachea. So after resecting the 2 to 3 centimeters trachea, you could be able to anastomose without any tension. So this is how we mobilize the trachea with the bipolar, so that the main, the success of this tracheal surgery depends on the preservation of the bilateral recurrent laryngeal nerves. If the patient has patent, normal, working recurrent laryngeal nerves, the outcomes are much, much better than a post-operative recurrent laryngeal palsy. This is how we loop the trachea, and we divide the trachea in the midline. We see the stenosis part. We resect the both ends. It is very important to ensure to have the healthy margins of the both. This is the stenosis part you can see here. So you can have, this is the stenosis part you can see here. This is, we are doing extra tracheal ring resection to achieve the healthy margin here. And And after this, ensuring this healthy margins on the both sides, now the anastomosis part starts. We do a delayed observable sutures under cross-field ventilation, and this is how we do it. So just before completion of the anterior sutures, we ask the anesthetist to push the endotracheal tube into the distal lumen, and we will complete the anastomosis. So this is the air leak test we do. There is no air leak, and the patient, we do always put these chin to sternum sutures. And we will extubate under the bronchoscopic guidance. This is the post-operative X-ray. Patient was, this is immediate after extubation. The patient is walking earlier. He was tracheostomized. This is immediately after shifting to the post-op ICU. And this is how, after a few hours of surgery, patient is able to walk on a treadmill. So coming to the next scenario, that is a cricotracheal stenosis. So this is the example of cricotracheal stenosis. Yesterday we have described the award-winning video. Dr. Srinivas is here. This is the cricoid split. So this is a novel technique where a cartilaginous graft will be taken. We split the cricoid and we'll place the graft we do anterior as well as posterior cricoid split depending on the scenario. So this is how we do the anterior cricoid split. We divide the trachea with a knife, cricoid with a knife, and this is how we'll harvest the cartilage. This is usually we'll take the right-sided second costal cartilage, and this is the final picture you get. This is the cricoid, and we have divided the trachea and the midline. We put the graft in between. So next, the third scenario is the main bronchostenosis with a completely destroyed lung. So this is how in these cases, there is no option except for doing a pneumonectomy. So this is how we have to achieve the pneumonectomy in these patients. You can see here, on the left side especially, the length of the left main bronchus has to be stapled or divided as close as to the carina, because to decrease the incidence of the bronchopleural fistula in the postoperative period. You can see here, this is the left main bronchus that is the arrow is pointing towards. It is as flush, as close as to the carina. And as well as on the right side, we especially want to reinforce the stapled bronchial margin with the pericardial fat pad. This is after right pneumonectomy. You can see the SVC. Actually, you can't see the right bronchial margin. It has been buried in the mediastinum. Mediastinal pleura was closed, and pericardial fat pad was reinforcing reinforcing the stenosis part. So then the fourth scenario is the lobar bronchostenosis with the destroyed lobe. You will see this more commonly here. This is a CT showing the patient is a doctor herself. Left upper lobe is completely stenosed, and the upper lobe bronchus is stenosed, and left upper lobe is completely collapsed. This is a bronchoscopic picture. You can see the left upper lobe opening is completely stenosed. In such cases, we do the normal lobectomy. And this is another case where the right main bronchus intermedius is completely stenosed. You can see the upper lobe bronchus opening there, and the right bronchus intermedius is completely stenosed. In these cases, we had to do the right lower bilobectomy. Now the question comes, what we do for main bronchostenosis with the preserved lung parenchyma. So these are very challenging cases where left main bronchus is involved, and the stenosis involves either the upper lobe opening or the lower lobe opening with collapse of the one single lobe. The other lobe is usually well expanded. However, the involved lobe is completely collapsed. You can see this picture. This is a young lady with left lower lobe completely collapsed with the left main bronchus stenosis, involvement of the left main bronchus opening. In such cases, we do sleeve resections. The concept of sleeve resection is we preserve the lung with the normal bronchus, and we anastomose it over the carina. Suppose the patient, this is the left upper sleeve lobectomy. We resect the left left main bronchus and the left upper lobe bronchus, and we anastomose the lower lobe bronchus over the carina. So this is a resection of the sleeve of the bronchus along with the lobe. So again, the similar case where left main bronchus is stenosed, and both upper and lower lobes are preserved in such cases. I will be presenting this left main bronchus sleeve resection. Sorry, this is not a patient where the tubercular stenosis is present, because we didn't record any video of that. This is a left main bronchus sleeve resection for left main bronchus adenoid cystic carcinoma. So, but the surgical principles remains the same. So, I thought it will be a good opportunity to share our this experience with you. So, this is a left main bronchus sleeve resection. We did the thoracotomy. So, we divided all the mediastinal pleura to expose all the hilar structures. That will be the left main pulmonary artery, the left main bronchus, the left superior pulmonary vein, the left inferior pulmonary vein. So, here we are dissecting the left superior pulmonary vein. We looped it. And this is the left main pulmonary artery. We have looped it. And these are the left superior and inferior pulmonary veins that you can see, both are beautifully seen here. Now we are trying to dissect the left main bronchus. Usually in post-tubercular cases, these planes are not that virgin. Since this is a tumorous case, the planes are very good. However, in tubercular cases with destroyed lobe, dense adhesions will be present, lots of enlarged, densely adherent lymph nodes will be present. The dissection will be much more bloody or much more dirty, I will say. This is a fantastically clean dissection you can see here. So we loop the aorta in these cases to gain the better exposure here, and see the left main bronchus actually goes very deep underneath the arch of the aorta. So we have to be very, very, very careful. So one side there is the left pulmonary artery, on the other side there is esophagus, above it there is arch of aorta. So the surgery looks very easy for you, but it is a very, very challenging situation what we see. So after entering the left main bronchus, we cut the bronchus, we will see both of the closed margins, then we start the anastomosis. That is the same technique that we have used, the continuous in the posterior layer, and interrupted we close anteriorly. So this is how at the end we achieve the anastomosis, and the lung is completely expanded. We will do the air leak test at the end, and this is the expanded completely lung. This is the post-operative bronchoscopy after 6 months, the completely preserved left lung with bronchial.
Dr. Mohan, can you conclude?
So the conclusion is definitely it's a complex clinical problem. Surgery has a potential role in tracheal as well as bronchial stenosis. The lung preservation is the norm. Bronchoplasty is proven safe and effective in these complex scenarios, and perioperative ATT is mandatory. So physicians think it's a medical disease, surgeons think it's a surgeon's disease. So it's not surgeons versus physicians, it is surgeons and physicians which will help us to tackle this complex entity. So once again, thank you so much for giving this great opportunity, and greetings from Center for Chest Surgery, Sir Gangaram Hospital.
Thank you, Dr. Mohan, for your presentation on the surgery in tuberculosis. In fact, before 1940, when the streptomycin was not there, the only intervention is the surgical intervention, but the surgeon's role has gone. They have taken the back seat with the advent of the chemotherapy. Again, we have taken the driving seat again in the light of ending TB by 2025. I think definitely have covered various surgical options which are available. But diagnosis, of course, interventions and surgeries definitely has a role. Are there any questions? One quick questions. If there are no questions, I thank once again Dr. Mohan for bringing back unfortunately, there are no thoracic surgeons in India. Most of them are cardiac surgeons. In the light of ending TB by 2025, most of you should take up the thoracic surgeries.
We are there, sir. Thank you.
Thank you. Shall we go to the next speaker?
Yes. Thank you.
So moving on from the cases of normal tuberculosis, we are entering into a more complex domain, that is MDR TB. So we have a talk on endobronchial valves for MDR TB by Dr. Sunil Kumar, who is a consultant in Aster, Bangalore.
Yes, good afternoon to everybody. At the outset, I would like to thank Hari for that Hercules job, what is done actually in terms of organizing one of the best quality programs which has been conducted when it comes to intervention arena and also a subspecialty for tuberculosis. Now, again and again, it has been proven out actually, need of the hour is a multidisciplinary where we understand the disease process. It's not a surgeon's domain, it's not a pulmonologist's domain. It's a mutual thing. The last slide, I agree with the surgeon who went through the things actually. Now, as a comprehensive care for any sort of a tuberculosis, we have drugs coming up in the picture. What are their limitations? And the iatrogenic resistance. The multi-drug resistance is the one sort of a scary stuff where we have a cure rate to the tune of 40 to 60%. Still alarming actually when it comes to your overall outcome, the disease, pill burden, and the complication what we need to endure. Before we get start with this is start with a disclaimer actually. I'm not an expert in the endobronchial valves. Still in India it's not been approved. And what I'm going to try to do in the next 20 minutes is to run through from the books what has been there and what is the literature, what is backing up from the Europe and the Russian groups who has done extensive work in this thing and try to assimilate all this thing. This was my short venture into thorax link actually, where I was having an opportunity to interact with the experts in the field actually to get this sort of a talk rolling out. Regards from the hospital from where I work. Now, today's book, now each and every sentence and each and every line can take up a whole day. Burden of tuberculosis in India is a burning issue which has to be addressed. I think if you start dissecting it each and everything, it can take up a whole day when it comes to diagnostic challenges. Now, in spite of being discovered tuberculosis way back in March 24th, 1882, till now we don't have a concrete test which can say that this is the TB. Unfortunately, it will be based on your clinical judgment and few of the lab parameters which can help to get a conclusive diagnosis of a tuberculosis. Therapeutic options. Now, this is one sort of an area where questioning, the science has evolved over a period of time in terms of questioning, unlearning, relearning, rethinking the whole process of how the genesis of therapeutic options which can be made a cookie-cut model for the what patient fits into this sort of a category. Resistance. I think from the drug-resistant MDR, XDR to the last of the scariest form of a total drug resistance. And on top of that, a combination with an HIV is one of the lethal combinations what we can anticipate in terms of drug-to-drug interactions, the outcome, the patient, the family, and the physician who is treating. I think it's one of the rarest combinations which we can just encounter with this out of a high amount of compliance to medication and the complication which is the culmination of this particular treatment. I'll not be dealing with all these things. I think I'll just throw a light upon burdens of tuberculosis in India out of the box stuff. Endobronchial valves. Where are the indications and what is the complication, what are the outcomes, what do you expect, and end the whole talk with some conclusion remarks. Now, this is not alarming actually. Probably it is mean known actually, where 27% of Indian population exposed to tuberculosis qualifies for one of the largest numbers of tuberculosis in India. Now, I think the mortality is also scary at the corner and the drug-resistant part. The iatrogenic intervention in terms of, I think probably in one of the studies actually, in a city like Bombay actually, where we have a stalwarts in the field of tuberculosis, more than 77 different regimes of tubercular medication was added for patient for treatment of tuberculosis. That shows that understanding and at the same time consistency in terms of delivering the best of the best, evidence-based, and to follow regimes which can help us so that the menace of resistance can be curtailed. Now, the drug-resistant MDR and XDR, the scariest part. Now, this is what's going to be a trend for the last decades, how we have performed in the last decades in terms of resistance. You can see that the third curve actually, which shows the multi-drug resistant, I think it's hitting around about 50% success rate when it comes to your overall management of a multi-drug resistant. And at the same time, from 2012, we started coming up with the XDR TB. Now, this is also one more sort of a stuff where 42.6% of tuberculosis are not registered. We don't have an accountable body which can get this sort of a scary thing managed in a very comprehensive way so that we have an accountability factor in terms of monitoring this patient, get them registered, follow them up so that the further resistance can be curtailed. Now at the same time, the right corner, we can see that a graph actually which shows that the economic burden in terms of treating tuberculosis. No doubt multi-drug resistant XDR TB patients need more than roughly 10,000 to 14,000 pills which has to be run through for minimum 14 to at least 20 to 24 months actually to get a control. It incurs too much of a financial burden to get this thing rolling. Are we in this sort of a situation? Yes, really, this is a situation where I think we have been pushed to the corners in terms of addressing the things in a comprehensive way. So in this case, I think probably we'll roll back on the historical part actually. Now, why did we face this thing? What is the history? What has taught us in this particular whole picture? If you see the evolution of TB, probably surgery was the one which was driving the initial force to get this thing under control. But later, went into a collapse therapy till 1944, where we come up with the streptomycin and all these drugs which came up in the picture too as a chemotherapeutic medicine which can try to help us to get this TB under control. In the modern era where drugs, different regimes, resistance factor. So the need of the hour is where sit across from the surgical and the medical and our overall disease to be addressed in a very comprehensive way. This is sort of a development of drug. I'll not dwell upon too much detail into this. And this is a new pipe. What are the drugs in the pipeline? Is more complex. It is getting more and more complex. And this is a different regime. So I think difficult for somebody to at least get all this thing by-hearted actually and to deliver it on a regular basis. So there comes the genesis of we are dealing with some patient who have a destroyed lung and the cavities. Now surgery. Now what is the role of surgery? No doubt remove a large area of abnormal lung. And also drug penetrability to this sort of cavities is low, where the surgery upscores the whole thing. Now cavitator lesion, any initial learning actually, 10 to the power of 7 and 10 to the power of 9 TB organisms present in the activity, the cavitary lesions. And a huge reservoir of multi-drug resistance. Genesis is also at this same point. And so need of surgical chemotherapy has to be work to get the good results in the terms of overall treatment response. When it comes to dwelling about the collapse therapy or a bed rest, which has been extensively talked up actually.
Sunil, can you come to the actual topic?
Yeah, I'm getting into this thing actually.
Almost 50% of your time is over.
Yeah, I'm going, sir. The rest and collapse therapy, because basically decrease the functional residual capacity, static tension on a wall of a TB cavity, and decrease dynamic traction, and decrease ventilation, anaerobic atmosphere, and also increase the blood flow. The ultimate thing is collapse of the cavity and the facilitate the ailing. This is one sort of a cartoon which shows that actually cavitator lesion with the strained vessels. As we go for the endobronchial blockers or endobronchial valves, there is a decrease in the quality, in the cavitator size, and the engorgement of vessel, which will increase the vasculature and also try to help in healing process. Now endobronchial valve, this is one sort of a paper which I will go to develop on actually and get this thing dissected. Now endobronchial valve treatment for destructive multi-drug resistant tuberculosis paper which was published in Web 2016, where effect of endobronchial valve treatment in treating of a destructive pulmonary disease, the safety aspect and the efficacy of the endobronchial valve has been discussed in length. Inclusion criteria where we have a destructive multi-drug resistant tuberculosis even after treatment for more than 12 to 24 months with a smear positive MDR TB with no bacteriologic conversion in spite of 6 months of treatment. And inform the exclusion criteria. Refusal to consult is the usual stuff, and repeated respiratory infections more than 3 times per year, and a purulent endobronchial secretions also one of the contraindication for this. And to study proper, more than 825 subjects were screened to this. See that more than 80 to 85% of people were excluded from the study. Only 1 or 2 patients were included in the study where they got into an open label randomized trial where you have intervention group of 49 and control group of 53. And they had followed up for more than 3 years, and at the end of the thing they were able to analyze the 49 intervention group and a control group of 53. Primary endpoint is bacteriological conversion and a cavity closures after 1 year of endobronchial valve placement. Safety also been checked at the end of this particular stuff. This is a Russian valve. I think these are the endobronchial hollow tube actually, and also the radial petals. And for this is a third, which is a start, which will be the area where we need to grasp with the forceps in terms of deploying this particular valve. And this intention of this thing is selectively curative atelectasis of the diseased part. Size, how do you opt for the size of this valve based on the bronchial diameter actually, it should be more than 1.2 to 1.4 of the bronchus to get this valve figured so that it's snugly fits in. To assess the size also, endobronchial forceps is also being used in the open condition to assess what is the diameter which has to be needed. The ultimate thing is unidirectional flow, so there will be distal atelectasis of the whole stuff. So this is where how we go to use a bronchoscope, where the floppy area we need to push the bronchoscope, holding with the forceps. The start will be holding with the forceps, and whatever the area what we desire to block because of the destructive process which is happening in the lung parenchyma, and this is the way how we're going to snugly fit this particular valve onto this diseased parenchyma. And the primary cavitation and the destruction pathologies are one thing which I will be addressing this particular stuff, and I think any endobronchial valve needs visual integrity to avoid that collateral ventilation part coming up in the picture. Now, when do we withdraw this endobronchial valve? When you have a stable conversion more than 3 months, complications or any absence of any effect because in spite of deploying of the valve, and if we're preparing for any surgical intervention, we need to remove this. So when it comes to intervention group, we have a therapy, second line drug or treatment for a medical kind of treatment, plus endobronchial valve as compared to control valve, which received only the chemotherapy regime. If you see that after 3 months, the effectivity goes up to 80 to 90% in terms of mycobacterial conversion in the first 3 months when it comes to intervention group as compared to 20 in the control group. When it comes to result at the end of 1 year, there's a good result in terms of mycobacterial tuber conversion rate to the 80 to 85%, and also collapsibility also was noted in more than 30 to 40%. Now, at the same time, few subset of patients who were also subjected for surgery in an intervention group 15 and a control group, it was 26 patients, where irreversible TB progression was indication for a surgery, localized form of a cavity TB with a continuous TB excretion in spite of getting 4 to 6 months of supervised ATT, failure of TT, and also a complication of a TB process. Now, this is what the results which you were able to get through. Cured case, no evidence of failure, or 3 or more consecutive negative cultures taken at least 30 days apart. And long-term results also were compiled. This is the one primary outcome of bacterial conversion was to the tune of 90% when it comes to intervention group of endobronchial valve as compared to the control valve with 20 patients. Chest X-ray features were complete atelectasis was noted in 13 patients as compared to ineffective in 7 patients, which warrants the further understanding of valve, is it the only way to go ahead in the future? And the cavitator status. Cavitator closure was to 33 in intervention, and the 27 patients were able to get this cavity closure within the 3 months, and the duration of cavity closure was minimal with that of a endobronchial valve as compared to control arm. The speed of cavity closure did not correlate with the cavity size, was a cavity which came up actually. The outcomes, long-term outcomes, no doubt better with the interventions. Cure rate was more than 60 to 70%. Our concept of relapse also was compared to your control arm was less, and TB progression also was much less with the endobronchial valve. Learning point, endobronchial valve, the safe, potential reversible procedure, low complication risk, and intervention associated mortality is also to the minimum. To conclude from this endobronchial valve paper actually, intervention lead to a reversible change in the respiratory function, complications are rare, reversible, and a faster bacterial conversion and a cavity closure which is noted, and further research on focus on endobronchial process, the disease process of regression has to be studied. Now the second study which has been, I think probably I'll just run through one such sort of a case actually, which will enumerate all these principles. This is a Zephyr valve which was used by Dr. Lorenzo Carbato in one of his series of 5 multi-drug resistant being treated. I'll just summarize this history. We have a 29-year-old female admitted with XDR TB way back in January 2011. And she was diagnosed with MDR TB in 2006. I think it took 5 years for MDR to convert it to XDR. And in 2011, the diagnosis was changed to XDR TB, and she was considered for ineligible for a surgical intervention. Now, sputum recorded heavy growth of mycobacterial tuberculosis, 2011. This was a regime. IV imipen with cilostazine, amikacin, linezolid, and clofazepine was added. No improvement in spite of chemotherapy for this XDR TB. Persisted to have fever, asthenia, and also hemoptysis. Well, next, in spite of all this thing, in May 2011, planned to go for a 4 millimeter valve into right middle lobe, and also added a terizodone, one of the chemotherapeutic agent actually. Follow-up, reduction in size in the right middle lobe cavity. Sputum conversion remained positive. Now, 2011, the new drug which came up in the 2011, bedaquiline, was also added. At the end of October 2011, cultures came negative, right middle cavity got betterment with each and every, as the valve been placed actually. And after 1 year of all these things, 2 endobronchial was removed. At the same time, the left upper lobe cavity also was blocked by a 5.5 mm endobronchial tube. After 10 months of follow-up, there was a good result in left upper lobe, also the right middle lobe. This was the CT scan which summarized the initial part, the right middle lobe, the endobronchial valves has been placed 2 into medial and lateral segment, good response. At the same time, left upper lobe also been addressed with the endobronchial valve actually is Zephyr valve with a 5.5 millimeter size. The editorial thing, hypoventilation and hypooxygenation of the lung. We are creating an aerobic atmosphere to anaerobic
Sunil, can you conclude?
Yeah, I'm coming, sir. I'm coming to the last panel.
No, because I can't give you any more time for you because...
And endobronchial valve placement resulted in reduction in the cavity size within 1 month. Sputum sear culture became negative 5 months after endobronchial valve placement. No endobronchial related complications occurred. This is one sort of a paper which shows about the complication rate when it comes to endobronchial closure, where they noted as a pyogenic empyema and also pleural calcification leading to blue bronchopleural fistula also being noted. The take-home message, no doubt, it's a multidisciplinary approach. Not one person who has become, the culmination of nutrition comes up in the picture, the microbiology, active cultures also be trained, standardization of protocol. No, RNTCP has been very handy in terms of implementing and all this stuff. And recently in 2020, we had changed into a National Tuberculosis Elimination Program. No more it's RNTCP, it is National Tuberculosis Elimination Program and a referral center. That's a referral center with a lot of commitment in terms of how to address this in a comprehensive, the need of the hour, ideal diagnostic test. Still we are wondering at actually what is the ideal test. Endobronchial, yet to come up in India. And we have to have a closed loop system to address in a comprehensive way. And time is ticking actually. We need to move fast, update ourselves so that we have a better world to get with much less.
Thank you, Sunil, for taking us to a hypothetical intervention in India, the endobronchial valves in MDR TB. I think we have some international faculty where they have any experience in endobronchial valve placing for the MDR TB. Because I am drafting the guidelines for the MDR TB for our country. There are only anecdotal reports outside and the FDA has not approved this. This principle is very simple. This is a collapse therapy, was not a new, the collapse therapy was there before the advent of chemotherapy. So this also a principle is same. So the need of the hour is to identify the MDR TB, treat completely, then there is definitely a role of surgery there we have included in the guidelines, the MDR TB. If there is a limited disease, we can treat, but endobronchial valve, I'm sorry that only there are anecdotal reports to my knowledge.
So I think the Russian population...
I think we'll go to the next session.
Thank you.
Because there's no point in discussing the intervention which has not there in India.
Thank you, Dr. Sunil, for your talk. And the next is a enigmatic question, TB versus sarcoidosis, and can interventional pulmonology make a difference? For this, we have Dr. Amit Tameja from Gangaram Institute.
Good afternoon, everybody, and thank you so much. I think TB and sarcoidosis is going to still remain an enigma after my talk. So just tell me if you're wiser, I'll be happy. IP basically before 2000 was primarily therapeutic, where we talked about rigid bronchoscopy, coring, stenting, and the primary indications were basically endobronchial tumors, maybe benign or malignant tracheal stenosis and bronchial stenosis, and that's what we limited ourselves to. With the advent of radial EBUS in 1990s and linear EBUS in early 2000s, the diagnostic role of IP grew leaps and bounds, and we have many papers in the last 2000 to 2010 from rest of the world where we talk about malignancies being diagnosed and staged with the help of IP. And since 2010, that this part of the world has had EBUS. Now we talk about many benign disorders in which IP and radial and the linear EBUS, to be very particular, will have a role in diagnosing these as well. So let's see why we are talking about TB and sarcoid in this country, because this is the first paper where we had about 300 patients, first 300 patients from our hospital. Almost 50 to 60% of disease burden which we tackle as a diagnostic bronchoscopist with linear EBUS is going to be benign, and we're going to deal primarily with granulomatous disorders of the lung in 50 to 60% of the population. And this is the main brunt where we are going to use IP in our sitting as well. And of course, as we can see, IP in tuberculosis, we have good 4 sessions, and IP has a very good role in all benign disorders of the lung, so to say. So malignancy is going to constitute only about 25% of our work. Mainly, we are going to concentrate on TB and sarcoid and rare granulomatous disorders. So let's see what are the characteristics of EBUS which helps us differentiate between TB and sarcoid. Of course, the first is the ultrasound characteristics of the lymph node. Second is what the cytopathologist tells you. And third is what the microbiologists tell you. I'll just go through each in a little more detail in the next 10 minutes or so. If you have a node which is symmetrical, which is homogeneous on CT scan, and you have a homogeneous ultrasound image with very preserved borders, no areas of heterogeneous or necrosis, of course, this by and large will term to be a case of sarcoid, but in case you have only a single node in the right paratracheal, left paratracheal, subcranial or hilar, and you have this morphology, it will be impossible for any pathologist to tell you whether it is TB and sarcoid, TB or sarcoid, until unless you have evidence of microbiological confirmation or necrosis. So in clean cases, symmetrical homogeneous lymph nodes and this type of a node, no doubt we are dealing with sarcoidosis. If you have a necrotic looking node on a CT scan, a heterogeneous node in an ultrasound, or you have this area of necrosis which you put in a needle and you aspirate pus, 99.9% in our country, we are dealing with the case of tuberculosis. But unfortunately, not all cases fall into these extremes of spectrum. We have cases which have, considerable gray in the spectrum, which is the job that we are going to do in the next 10 minutes. So when we compared whether a type of granuloma can help us differentiate between TB and sarcoid. This was a study in 2012-13 where the pathologist was blinded to the clinical history of the patient. They were not told whether the nodes were symmetrical, asymmetrical, what was the clinical background of the patient. We followed up the patient for the next 6 months, and based on what their conjuncture was, they were not able to differentiate between TB and sarcoid. Of course, if you have necrotizing granulomas, it will definitely go more in favor of tuberculosis. But in case you have only compact granulomas or loose scattered granulomas without obvious necrosis, no pathological examination can 100% prove whether this particular node is TB or sarcoid. And the most common, this is another paper where we analyzed our 129 TB patients. Most common finding is necrotizing granulomas. Granulomas was seen in about 40 out of 125. 20 out of 125 cases had only necrosis. All of them ultimately turned out to be tubercular. Of course, inadequate sample in 3. So as far as cytopathology in tuberculosis is concerned, the sensitivity is as close to 97%. But when we have only granulomas and no necrosis and no microbiological support or evidence to prove or disprove tuberculosis, the yield for EBUS is 80%. That I would be limiting myself to 80-85%. That's what most of the centers are getting. In case you are using newer needles or in case you are doing internal forceps biopsy, which I will talk to later, we might go up to 94% also. But the yield for cytology for tuberculosis will be higher than what we see for sarcoidosis. Now, another very interesting fact which came out of our paper was where CT and whether necrosis judged by CT was compared with necrosis judged by the pathologist on the slide. Now, out of 125, 50 patients had necrosis on CT, and out of that 44 patients, pathologist was also able to pick up necrosis on the slides. But in almost 50% of cases out of 75, the pathologist was able to see necrosis on the slides which was not present on the lymph nodes. So the sensitivity and the yield of picking up necrosis definitely goes up by at least 50% if you are using some diagnostic technique, maybe a blind TBNA or a conventional TBNA or an EBUS. You would be able to pick up much more necrosis than what the CT is going to tell you, which makes you wiser in taking the decision whether this patient has TB or sarcoid. Most importantly, we all have to rely on a microbiologist to give a correct answer. Now, if you do conventional staining, the yield in the literature varies from about 20 to 30% for ZN and DF stains, and the culture positivity rate is between 50 to 60%. That is when you send the sample for microbiology only in saline, and direct fluorescence or ZN is done only in the saline samples, which are of course diluted. What we do in our hospital routinely, and this has tremendously increased the yield of ZN or a DF picking up to almost 50 to 60%, is that we do stains directly on the slides which are prepared. So the slides are sent to the pathology department. The pathologist stains all the slides. They select the slides which have the most necrotic tissue, which have the most number of granulomas. 1 or 2 slides are destained, and then they are stained for tuberculosis. Only by doing this, by adding Zn or Df stain directly to the slides rather than limiting Zn or Df only to the aspirate material that you send in microbiology, the sensitivity of microbiology goes up to 84%. 60% of cases you will be able to pick up on staining, and as much as 50 to 55% cases you will be able to pick up in culture. AFP positivity on slide we saw in our series of 125 in 45 patients. In saline it was 27 plus 9, only 33. Definitely significant. The combined positivity of staining done both on the slide and on aspirate material can be as high as 64%. We haven't been able to replicate the 64% in any of our subsequent papers, but we are roughly hitting about 55% positivity in consistently in when we are staining directly on the slide, and this is a significant improvement than 20 to 30% which the world literature reports.